to get answers to your questions. But someone did ask about how PSHAN supports private health facilities to access financing. Should they meet you after the panel to get those answers, or do you want to quickly? Okay, so just meet Dr. Tinola immediately after the panel. Someone asked how we can demonstrate utilization of the less than 5% that the federal government has been allocating to make a case for 15%. Dr. Idris?
Come again with your question.
So someone wants to know how we can demonstrate utilization of the less than 5% allocations that have been coming from the federal government so far, so that we can make a case for 15%.
I think it's just advocacy too. Advocacy. I remember, okay, let me put it this way. During the election, just with campaign time, we said one of the things we were driving at was to put health on the political agenda. That was one thing. And the essence is that you need to make people in government who are going to rule understand what health is, how health is an economic driver, and health is an industry, as an economy. You need to let them understand that. Having understood that, they might be in a better position now that they educate them to invest in the health sector. And part of that investment in the health sector is to increase budgetary provision to health. Take, for instance, how many states, how many people even understand the health accounts? Apart from the federal, at least only 1 or 2 states understand that. But that's a tool that people can use to educate people in government. This is how much you're expending on health. This is what you're using your money on health for. Take, for instance, you're spending about less than 9% on preventive care in this environment. Nobody in government knows that until they are told. They look, you're not doing, but you spent a lot of money is coming from the private sector out of pocket. The people in government don't know that. They need to be educated. It's when you can gain their trust, when they listen to you. Now they can be more inclined to put more money to invest more in the health sector. And it's not enough to invest in the sector. You have to look at the environment where these people are going to operate. So, and people, again, it's a combination of everybody's role. Everybody has a role to play here. The technical people, the private sector, the people who are good in health advocacy, communication, etc. People have to get involved in all these things.
Thank you so much. Thank you for sharing this. So I think we would wrap up this panel here. This has been a really insightful panel. We've heard about how important it is to have good governance and an enabling environment for private sector investments in health. We heard about legislation, regulation. We also heard about how important proofs of concepts are. We heard from the NSIA, from PSHAN, how they have proven that it works. And this just gives us lessons to take forward in how Nigeria can further strengthen its health systems. Our fiscal space is really small. Resources are finite. And it's important to demonstrate the use of the resources that we do have and to use private sector resources to plug the gaps that exist. We've heard from the Lagos State example as well, how they demonstrated that private sector could help boost accountability, transparency, and improve the quality of care that's being delivered at health facilities. Please help me thank my distinguished panel for sharing their thoughts. And I would also like to thank the entire audience. Thank you for engaging, for sharing your questions. Thank you very much. Let's take a good picture before you go.
Plus for the panelists. Please let's put our hands together for them. Thank you for that awesome conversation and for contributing immensely. So we've been sitting for hours now, and as a rule of thumb, I think we need to stretch a bit. What do you say? Do you agree? I hope we all use fitness apps, right? Innovation helps you watch how much movement you've had in a day. So I'd like us to rise on our feet. Let's stretch a bit. Please rise up. Please rise up. We'll do a mathematical stretch. Are you ready? We're having a mathematical stretch. Now, don't worry, tea break is coming very soon. We're having a mathematical stretch. Do I have your attention? Okay, not everyone is answering me. Do I have your attention? Okay, what is 1 plus 1, everybody? Okay, so this is what you do. 1, everybody, 1 plus 1 equals 2. You are very good students. Let's do that again. 1 plus 1, let's go. 1 plus 1 equals 2. Let's move it up a bit. 2 plus 2, you know what to do. Let's go. 2 plus 2 equals, bend over. 4, touch your feet. You can't touch your feet. All right, what will be 4 plus 4? How many of us can actually bend over? This is a health conference. You've been sitting a lot. All right. So well done. Let's take a seat. Thank you all for participating. Let me not break your waist. Okay. Thank you all for participating. Okay. So we'll have our fireside chat conversation coming up next.
Thank you, Wemimo, for leading that session. So quickly we go into an important fireside chat. We've been talking about private sector involvement since morning across different areas of healthcare, innovation, research, financing. But it's also important to hear from those who are doing. Because for this conference, it's okay to profile solutions, we share recommendations of what can work, but then it's also important to share what's already working. So people sharing their experiences, that way we can glean insights on how to move it forward. So I'm really excited to invite Kate Killand, who is a scientific writer at Coalition for Epidemic Preparedness Innovations, to lead this important fireside chat. She will be introducing her panelists. Kate, thank you.
Thank you very much. Thank you. Good day to everyone here. It's an absolute delight for me to be in Lagos. There's been a lot of talk about complexion. Mine definitely stands out here. But I have to say, I was actually born in Nigeria. I was born in Sokoto, up in the north, and my parents got married a few years before that in Lagos, in a church in Lagos. So I'm absolutely delighted to be able to come home to my country of birth. I'm also absolutely delighted to be joined today by a couple of very important experts to talk about a very important and threatening disease. Lassa fever is a constant and growing threat in Nigeria and across West Africa. And while there has been some progress made in the study of this disease and how it spreads and the epidemiological aspects, as well as some progress towards the development of vaccines, there is still no vaccine and no cure. So what I'm going to be doing today is hosting a fireside chat with two local and international experts. And what we're going to be doing is delving into the status of Lassa fever within Nigeria and West Africa, and also the scientific progress, the latest progress that has been made, but also, really importantly, leading a discussion on how the private sector can become more involved in the development of countermeasures, medical countermeasures for Lassa fever, and how we can push that forward together with public and private sector involvement towards eventually, hopefully, the licensure of a vaccine for Lassa. So I'm going to be joined today by Professor Alashley Abimiko, who is the Executive Director of International Research Center of Excellence at the Institute of Human Virology in Nigeria. So if she'd like to come to the stage, please. Thank you. Welcome. And I'm also joined by Dr. Donald Grant, who has joined us today from Sierra Leone. Dr. Grant is the Chief Physician at the Lassa Ward in the Kenema Government Hospital in Sierra Leone, and he's also one of the principal investigators for the ENABLE program, which is a large epidemiological study into Lassa. Thank you both. I'm going to come and sit down with you now. Thank you very much for joining us. I'd like to start this discussion really with an overview from each of you of how much progress there has been towards an effective Lassa vaccine, and how soon you think it might be that the people of Nigeria and other countries in West Africa might realistically be able to have this kind of protection from this disease. Can I start with you, Professor?
I'll start. First of all, I'd like to join you in thanking the organizers for inviting me to this. Really interesting. I hope people can hear. Okay, you can.
Yeah.
Just thanking the organizers for inviting me to this session. The first half of the day has been really interesting to listen to. And, to answer your question, Kate, I mean, if we look at the Lassa epidemic, we know that it's not going away. Is really affecting significantly the western region of the world, the western part of Africa. And so for us, especially in the continent, we're really interested because for the first time, there is some action or some effort being done to a disease that is affecting only a section of Africa continent. So we're very excited about that. Certainly, if you go to the website of the Nigerian CDC, you will find out that Lassa is a problem that's not going away. Mm-hmm. So if you look at the trend, you would see that in the last few years, it has continued to rise and even spread. So, and this is also a disease with really great fatality, and I know he's going to talk about the clinical issues of it later. So it's an important disease that must be addressed. And like other viruses, having an effective treatment is really a challenge. Mm-hmm. So having an effective vaccine is more or less, along with other interventions, is more or less the way to go. So I think it's very exciting that the discussion is on the table. I'm very excited about all the epidemiological work that has been done across West Africa to really understand the spread of the disease and the incidence. And really thankful to CEPI that they've been one of the, and I don't know whether this is private now, but they have been one of the organizations that have actually put in the funding to make sure that there's a safe vaccine that can be experimentally tested to see its efficacy to Lassa. So in terms of understanding the incidence and the spread, I think that there's great progress being made with great collaboration across West Africa. And then in terms of possible candidates, I think there's a portfolio that is worth testing, and there are manufacturers that have been involved. And I know we'll get into some of the discussions in terms of the collaborations that have made that happen.
Yeah, and Dr. Grant, do you also, I know that you have a lot of hands-on experience with Lassa patients, do you feel that there is wider awareness now of the problems that Lassa poses, and do you also share that excitement, if we can describe it as that, at the progress that's being made against this disease?
Yes, thank you very much, Kate, and let me also join you to thank the organizers for inviting us here to discuss a disease that I usually refer to as one of the neglected diseases, in as much as it has been causing so much challenges for the people of West Africa. And I've been involved in managing Lassa fever for over 10 years, and so it's one of those diseases I'm very much passionate about. Lassa fever has been one of those diseases that can mimic any febrile illness. And so we have been seeing mortality of Lassa fever varies across the countries. And we are seeing so much cases of Lassa fever currently in Nigeria, but the mortality is quite different compared to even in Sierra Leone, wherein we are seeing a little few cases, but a very high mortality. And this could be possibly attributed to a possibly strain variability. Initially, we talk of Lassa fever only in few countries, the Mano River Union, which is Sierra Leone, Guinea, and Liberia, and then Nigeria. But we've been seeing a spread into new countries like Mali, Togo, Ghana, right, Cote d'Ivoire. And so this calls for an alarm wherein we really need to do more. And we're so excited, to have our governments across West Africa, but also CEPI to come on board to say, okay, guys, you're all working, you're all doing your bit, but it's time that we all come together by having one of the largest epidemiological studies across 5 countries, wherein we'll be able to understand the epidemiology of Lassa. Lassa has been with us for over 50 years, but yet still, the clear epidemiology of it is not well understood. The data that are out there were data of studies done 30 years back, mostly in Sierra Leone. And so it's kind of outdated. We need to get new information. With this new information, we will be in position to be able to do vaccines trials, even therapeutics. I know we're here to talk about vaccines, but as a clinician, it's also important that we also look at that aspect, right? So we're so excited to have candidate vaccines already rolling out, right? And some already completed a phase 1 trial. And interestingly, one being done in West Africa, that is in Liberia. So that brings that excitement. And for us, we are looking at the EPI studies are geared towards building capacity in country. And most interestingly, that these EPI studies done across these countries were all led by the nationals. This is what we are talking about, building capacity for future trials.
Yeah.
So I think I will hold on there for now.
And I know there are several potential vaccine candidates. So is any of them looking particularly promising in your view? I mean, how far ahead are these vaccine candidates at the moment?
As far as I know, there are probably 3 vaccine candidates that have some potential. They've already been tested and been shown to be safe.
Safety, yeah.
As you know, with the collaboration between the North and the South, it's important to, especially if the manufacturers are coming from the North, that is tested in their populations first and shown to be safe. And it has been.
Yeah.
We're at a stage now where it's been tested in our populations, and certainly in Ghana, and he talked about another phase 1 in Liberia, and they are showing promise in the sense that they are safe, and they're showing the kind of immune responses that we expect to see to gain protection. However, as you know, with most vaccine clinical trials, you've got to go to the phase 2 with a bigger population now that you've shown that it's safe, and to go to a larger population to show that it can protect. And that's why the study that he mentioned earlier, the ENABLE study across these countries, to understand the spread, to understand the risks in terms of exposure and to understand the populations you need to vaccinate to show efficacy of those vaccines is very, very important. So I'm really excited. There's obviously there are products, otherwise it wouldn't have gone into phase 1. So very exciting that phase 1 is showing safety, and then we're looking to feature vaccine studies that would show efficacy. And I believe it was probably about 2 months or 3 months ago that there was a meeting, an international meeting here in Nigeria, in Abuja, with the manufacturers of the vaccines, that there was those discussions. And some of the earlier discussions we heard in this panel in terms of the collaboration, and obviously if you're going to talk about manufacturing vaccines and doing a vaccine clinical trial, you do need the public-private partnership. So I think that's a really good case to show that happening.
Yeah, so Dr. Grant, I mean, you're very involved with the ENABLE study, which of course is one where CEPI, the Coalition for Epidemic Preparedness Innovations, is working with partners locally. And much of this epidemiological work and the deeper investigation of the disease and its spread and so on has been carried out and directed by public organizations, publicly funded organizations, government institutions, government hospitals. But do you think that the private sector has a role to play in that kind of research as well? Could the private sector support epidemiological studies or even vaccine trials, even if they're not directly involved in vaccine development?
Yes, I think so. The private sector has a critical role to play. If we look, most of the past years, it has been more of the public sector being involved, and then we have CEPI coming in. And so it's also time for the private sector to really come on board to ensure that the bottom line is government cannot do it all. I usually refer to Lassa fever as a neglected stepchild. And, I was discussing with someone, we all know in Africa, if you're a stepchild, that's a problem. And then you are neglected again. So that's a double impact. But somebody also said, I think it's not just a neglected stepchild, but the father also has died. So making it very complex. So the importance of the private sector to come on board, it's really critical here, because when we look at the EPI studies, we don't want to stop it at the end of the ENABLE 1.0. There is still so much more we need to know. We are talking here about 80% of cases being asymptomatic. Currently, the data we are seeing, we're realizing that there are people that are serologically positive for Lassa fever without them even knowing. And samples were drawn from areas that we've never drawn cases from. And so this is also something that is alarming. We still need to know more about it. So the private sector can come in, work with the research institutions, support so that we can study more about this disease, which has one of the highest mortality when it comes to pregnant women and children. So the private sector can play that critical role. If we move from the EPI studies, we go to the vaccines. I think now I'm asking myself the question. This is a disease that we see mostly in West Africa, right? And where it is very much challenging when we talk about accessibility to vaccines. So we need to get the private sector on board. We start discussing issues of production, because we just don't want to get a vaccine, but then accessibility is a challenge. So here is where the private sector can come in, help with the production, subsidize in even making it available, so that it will be available for everyone. Right? Or else having a vaccine that is not accessible or affordable will almost mean like we've not made progress. So the private sector is key, and they are important to work together. Yes, the public sector provides the policies and all of that, but then the private sector comes in, to bring in those subsidies and work with research institutions for production and then distribution? Thank you.
I was going to ask you, Professor, sorry, we talked last week a little bit about this, and one of the things that you said was so important to incentivize the private sector. I mean, we can sit here and say, we need you, or we want you, but what's the incentive? And you talked about making a business case. Can you explain a little bit about that?
Absolutely. I think the earlier panel really made my job very much easier, because all of them emphasized the importance of having a business plan, understanding how the private sector works, understanding their discipline, and providing that as a plan for them. Now, there's something else that Dr. Idris mentioned, and he kept on talking about the fact that, the private sector has the technical capability. And that technical capability is in all spheres of research until it gets to the production line. The private sector is not just there for the product. So having even this enabled study, them being part of it, them analyzing it with you, being part of the research, is something that they will appreciate. So they bring their intellectual. So at the research arm, there is that intellectual interaction that you're having with the private. And then you have your business plan. Here is how we're thinking of it. And like he was pointing out, these are the plan to produce it, to have it access, to involve the regulatory bodies, which they know a lot about. So when you look at the whole consortium of research and then finding the intervention and making sure it gets to the individuals and assessing how well it's working, this is what they do day in and out. So they really have to be a partner right through. We cannot dictate to them when they come into the equation. They have to be, I think someone mentioned earlier that all these diseases affects them as well. That's why they really are into finding drugs, finding vaccines, helping to cope. But we seem to segregate where they come in and where they go off. And it shouldn't be. It should be in the whole story, so that it's really true partnership and we all celebrate in the end when we get something, rather than going to them when we need money, when we need an equipment, when we need something. No, there are a lot more than that. Currently, we are involved in looking at non-communicable diseases among people that are aging with HIV, and it is the private sector that is funding it. And we have research meetings, and we discuss the data and everything together, and even the design of the product. So I think that this really, we have to change our mindsets, and this is really a great beginning to do that.
And one of the things, of course, that studies like Enable is showing is that there is a market, and it's a big market already, and in fact what we may be finding out through Enable is that, as you discussed earlier, that it's spreading, that it has a higher mortality rate in some areas, possibly due to strains and so on. So it is an unmet need, without a doubt. I mean, hundreds of millions of people could benefit from the protection of a vaccine or other medical countermeasures. So there's no doubt that, I mean, this isn't a black hole, if you sort of mean, going into something where you may not use the product or so on. So I wondered whether we could just talk a little bit about the pandemic that we have just been through, the dreadful COVID pandemic. And in terms of Nigeria's response to COVID-19, were there any particular lessons that you think could be learned from that response and applied to the work on Lassa? I know that one of the aspects of Nigeria's response was a massive ramp up in testing. Are those kinds of lessons being learned, and are they able to be applied when we're talking about counteracting Lassa fever?
Yes, I think I will speak broadly for Africa and more precisely Sierra Leone. When we had COVID-19 back, you could see we had to ramp up testing for COVID-19. And there were challenges in setting up labs in strategic places. We had only few labs that could handle testing initially, but then we had to scale up. Right, and that was possible because we had support from other agencies that came in. And so I think also for Lassa fever, I usually say, if you don't look for it, you will not see it because its presentation mimics any other febrile illness. So there is that need to also scale up testing. And this aligns with the WHO R&D, which looks at 3 MCMs, which includes therapeutics, the vaccines we're talking here about, and then diagnostics. So diagnostics is really key, right? So we really need to expand testing, especially point of care testing, right? Yes, there are PCRs there, but we also need to expand point of care because these events do happen in hard to reach areas. So point of care testing for the healthcare workers will be important. And then development of PCRs testing, that can also be strain sensitive because we're seeing different strains circulating. So that is also key, right? And lessons learned also from the COVID-19. We were in position to scale up vaccination because it was readily available at that point. But then there were issues of it being distributed across countries, right? So I think what we need to look at, the private sector being brought in not only at that end stage of things, but from the beginning as we start discussing things. So that they can also support logistics in terms of its production, its distribution, because those are the challenges. We need to get these vaccines to the hard to reach communities, with not just having it sitting in one central hub and then you just use it as a reactive approach. But so that is why it's important that we bring from those lessons learned from the COVID-19, how we were able to scale up testing, we were able to scale up vaccination, and we could not see much impact of COVID-19. I think we also need to look at those strategies when it comes to Lassa.
Yeah, and Professor, what are your reflections on Nigeria's response? Were there examples in Nigeria's response to COVID-19 that can be useful for Lassa, for the building up of progress against Lassa and the development of a vaccine?
Lots of examples. I feel that some of the lessons that is useful to some of the discussion we're having today is how the private sector and the private laboratories also contributed to all of the testing, right? Within Nigeria is 200 million individuals, and you've got the whole thing affecting the whole continent within a short period of time. So the private laboratories that were able to do the testing really quickly and also train additional public health labs were really helpful in that and will be helpful also for Lassa vaccines. Now, the thing with Lassa vaccine is because it's not unlike the COVID, the Lassa vaccine is still an experimental vaccine. It means that every single test that you're going to do has to hit international standards. And the private laboratories and expertise would really support building that up, and really. And again, when they come to the table, they're talking to their peers, right, from the north, who kind of have a little more confidence in the fact that there are people that understand our language that are involved in helping the countries in West Africa to build this vaccine. So, through COVID, you see how much the private sector has really contributed to having a vaccine available within a short period of time. And with CEPI's vision of addressing epidemics and pandemics within the first 100 days, the participation of the private sector in ensuring that the vaccines are there and they are available, like he was saying, within that period of time, is really going to be key. And we saw that in COVID. It is the private sector that we're really involved in getting us vaccines that fast and getting it to the population that fast. And in terms of LASA, I think that all of the things that were discussed during the COVID era, especially when it had to do with the disparity between the North and the South in accessibility to available vaccines, LASA allows you to really test that. Because one of the things that came out of that was, well, we don't have the capacity to do the production at the time that our people need it. And here we have a vaccine that is going to be really done here in collaboration. And so an opportunity to work out issues that have to do with acceptability and access that would inform future vaccines as well.
And on that, on the idea of future vaccines, CEPI's work is often based around viral families, and Dr. Grant, I don't know whether you could talk a little bit about why Lassa is so important as a representative virus of other viruses in that family that could pose a threat as well.
Yes, Lassa will be used, and I think should be used as a template, because it's, as I mentioned earlier, it has been there with us, neglected, and so with mortalities really on the high side, having outbreaks, I will say, year-round, and so it can be used as a template to understand how we can get vaccines and then roll them out and see its impacts, immediate impacts. You don't need to wait like for EVD, Ebola, to wait for another outbreak. It's kind of like happening year-round. Even in Nigeria, even in Sierra Leone, we get cases year-round. So it can be used, and we'll be able to see the impact of these vaccine like almost immediately. Right? So it's important that Lassa is being prioritized, and this is also in alignment with the WHO blueprint, looking at prioritizing Lassa fever. And its socioeconomic impact again. We don't need to wait. We don't need to wait. And so having such a vaccine is really critical, that can serve as a template for others.
And I mean, just a word about, I know we talked a lot about how it's important to bring the private sector in all the way along, so at the data analytics and the expertise there, the testing and diagnostics. But what about manufacturing, vaccine manufacturing in Nigeria? Dr. Salma Anas noted earlier at the beginning of the conference that Nigeria wants to get to a position where it produces much higher percentage, up to 60% of the vaccines that it uses at home nationally. Do you see that as possible, and do you see that as the major contribution of the private sector and further down the line, or do you think that the way to get to that point is by bringing the private sector in all the way along? I know that's a slightly leading question, because I think
that's true. So again, like you were mentioning earlier from the COVID-19, there was a lot of talk, wasn't there, especially now with social media, about how do we really believe these vaccines that are coming from elsewhere, that we haven't been part of it, and all of that. And, I believe it was the Honorable Minister of Health that mentioned, or probably the, I'm sorry, I'm forgetting her name, Dr. Salma, that mentioned that Nigeria used to produce vaccines, used to produce yellow fever vaccines and polio vaccines. And in fact, there are sections of Nigeria that still produce husbandry vaccines. So humans and animals are not that different, but
No, exactly.
that technology is still there. But I think, as we deal with the issues of false news and the really misguided information that is out there on vaccines, it's really important that the private sector is involved in, as you mentioned, all of the processes. But there are areas that their expertise and their focus is really going to be key. One is in the area of manufacturing and ensuring that there's access, because even during COVID, when Nigeria was being put forward as producing its own vaccine to counteract the effects of not getting the vaccines when it's needed within its population, there was talk with the government, with I believe it's Mayhem Baker, of the BioVaccine venture that was formed. So I'm glad they call it BioVaccine. So it's for any possible vaccine, not just COVID vaccine, but it's put in place a structure. I truly believe that based on its history, based on all of the conversations and the infrastructure that has been put on ground already, and based on a very close partnership, there's no reason why Nigeria shouldn't be producing its own vaccines, including Lassa vaccines.
Yeah, and I think it's important. I mean, coming from Sierra Leone, Nigeria has the market already 200 million plus. We're having a population of 8 million, and which is possibly a small area in Lagos. And so I think having such a producing or a factory right in Nigeria will help a lot West Africa, right? And there are also discussions of having such already in Senegal. So if we have these hubs in production hubs in West Africa, it will help immensely in combating Lassa fever. And then we will learn from our big brothers, and then we will be thinking of having our and big sisters, and then we'll have our production centers also.
And of course, with the vast amount of human and technical resources in Nigeria, it makes sense that it would be a regional champion, a regional hub. I'd like to take a couple of questions from the audience, if there's anyone out there who would like to ask a question. I can see a hand. It's quite difficult to see anything because of the bright lights in my eyes, but sure. So I'd like to take the question right in front of me there, please. Thank you.
Okay, my name is Jethro from Data Hub Limited. As said during the discussion, we know Lassa fever presents symptoms similar to other illnesses like malaria and typhoid. So my question is it possible to develop test kits to discover probable case, such as positive Lassa virus, specific IgM antibodies in the blood or other body fluid? Because we know early diagnosis will help prevent the spread. So is it possible to develop test kits that can be used maybe in primary health care centers or by other community health workers in the communities?
Yes. It's currently there is one or couple of others of RDTs, rapid diagnostic test kits for Lassa fever, and it's done by the Zalgen Group, and we worked on it so much in Sierra Leone. And one thing we realized that it worked well in Sierra Leone, but there were challenges when it was used in Nigeria. This could be attributed to the strain variability. So there are groups working on that. So there's currently one that is available, right? So what we need to look at is how readily available that one is, because that's again the challenge, the cost for it, and that's where the private sector needs to come in, because not everyone can afford it, not all the institutions can afford it. So if we have the private sector coming in, then it can be subsidized and then be made available and rolled out.
Yeah, and if I could just add to that, earlier on we talked about the importance of having the private sector in all spheres. I know there are research that's going on, for instance, to see if somebody comes in with acute febrile illness, which mimics all the diseases that you've mentioned, malaria, Lassa, typhoid, is it possible to have this point of care that can detect which of these agents is causing the disease? So that, again, is really true partnership between academia, clinicians, and our private sector to make sure that we can develop such product.
So on that note, I've been asked to wrap up because I know that we all are needing to have some coffee and some lunch and a stretch. But this is all about partnerships. So while you're having your coffee and your stretch, please talk to each other. And let's see if we can progress towards a Lassa vaccine further with some new conversations and partnerships at lunchtime. Thank you very much indeed to my guests. Really appreciate it. Thank you.
Thank you. Very nice. They need okay.
Stand.
You want to stand?
Should we sit or stand? I don't know.
Which one do you?
Thank you.
Oops.
Thank you very much. Please put your hands together for that awesome conversation. Thank you all for joining the panel. The Fireside Chat has focused a lot around what is being done and how we can strengthen that. Thank you, Kate. All right, it's time for a tea break. I anticipated that. So to make this easy, we have about 3 serving points outside. So just pick up your coffee and network. Now we have partners and supporting organizations that haven't spoken, but they are right here in the audience. We would like you to meet them, to say hello to them. I'm giving you an assignment. So when you come back, I would randomly ask you who you met, and you have to meet someone you have not known before. Because I know you might be sitting beside someone you know. So please meet at least one person, network. Your next money might be just sitting right beside you. You know, right? All right, let's go for a tea break. We'll have 30 minutes precisely on the clock. Please, let's be back by then. We have another panel session waiting. We'll see you back in 30 minutes.
Hello, everyone. Thank you. We like the engagement. We like the networking. Remember to take a selfie with someone you just met and share using the hashtag. Share other insights that you're getting from the event using the hashtag PS4HealthNG or FHC 2003. Please, if we can start making our way back to our seats. We are conscious of time. We're already running behind time, so we can get started for the second panel session. If you still have your food, you can bring it to your table. You don't have to dump it. So if you're not done, please, let's start making our way back. Thank you.
Hello, everybody. Time up. Please come back into the hall. If you can hear me outside, please come back into the hall. Time is up. Please, can you beckon to the people hanging around the lobby to please come back in the hall so that we can start the next session. So how was your break? Hello? Hello? Anybody home? Hello? I'm here. How was your break? So we're going to play a little game before we go on to the next session. Are you ready? I'm not sure. Are you ready? So do you have a phone? Did you come with your phone? I'm sure you did. Please raise it up. Let me see your phone. Please let me see your phone. If I can't see your phone, you're wrong. Please let me see your phone. Okay. Go to your camera. Open it. Open it. Open your camera. Open the camera. Yeah. Now take a selfie with the person sitting close to you. Make sure you're smiling. Go ahead. Go ahead. Go ahead. I'm watching. Take a selfie. Move closer to her. Fill up the gap. Close up. Close up. You look good together. You all look very beautiful. So take a picture. A group picture on your table. Now, very good. Now go to Twitter. Run to Twitter. And post it on your social media handle. Are you there? Who's showing me? Type hashtag PS4HealthNG. Put it there. I'm watching. Whose picture is coming first? Please watch for me. Whose picture is coming up first? Are you on Twitter? Have you posted? Make sure you're tagging Nigeria Health Watch and make sure you use the hashtag PS4.
Just pull it down. Yes. That's
Have you done that? PS4HealthNG. Have you shared it? Please answer me. Have you shared it? Almost. Have you shared it? It's either a yes or a no. There's no almost to post. Have you shared it? All right, I'm going to call 2 people randomly out here. 2 people randomly. Do you want to volunteer? I need 2 people. Aha, you've been volunteered. Please put your hands together for her, the lady in the orange top. Please help me make her welcome as she comes forward. Please give me a microphone. I need a microphone here. Please clap for her, encourage her as she comes up here. Great. I need one more person. You can recommend somebody. I need one more person. Come on, people. Be great sport. Should I call you? Do you want me to call you? Okay. Mini, mani, mo. Let's see. Okay. Gentleman wearing the gray. Okay. Oh, he's heading outside. Hello, sir. You are in the walkway. You are in the walkway. Hello? Oh, all right. Can you hear me at the back of the hall at all? Please call that man for me. No, the one standing right here, in this circle here. Come forward, come forward. Usher, come forward. Yes, come forward. Come. Please call the man wearing the gray right beside you there. No, the one at your back, behind you. Yes, he. Please help me welcome him as he comes forward. Put your hands together. Yeah, you are not listening to me. He doesn't even know what I'm talking about. Please help me welcome him as he comes forward. We're waiting for you, sir. Please come forward. Please come forward. We're waiting for you. We are waiting for you, sir. Okay, you come. You are ready for me, so please come. Do we have a microphone? Do we have a microphone ready? Okay, thank you so much. Can we put our hands together for these beautiful and handsome people? Thank you so much for coming forward. So we're going to play a quick game. Oh, where's my phone? We're going to play a quick game. Thank you. Please help me just give them one each. One microphone each. Thank you. All right, we're playing concentration. Do you know how to play concentration? Ah, my good Lord. We're not heavy from tea break, are we? We're not heavy, all right. We're playing concentration. So I'm going to give you a letter very quickly. I'm still waiting for your pictures on Twitter, by the way. So I'm going to give you a letter. Are you going to give me 10 words that start with that letter in very quick succession? Who will be my timer? I need a timekeeper. Who's volunteering? Are you volunteering? No. All right. So I'm going to give them a letter, and then you give me 10 words that start with that letter as fast as you can. Are you ready? Yes, you do one, and then she does another one. Are you ready? Answer into your microphone.
I think so, yeah.
No, you are ready. If you're here, you're ready. All right, let's go. So concentration. Give me 10 words that start with the letter L.
Layman.
Love.
Law.
Letter.
If this was a game for 10 million naira, you just lost the money like that. All right, let's try another one. Put in a little more effort. Let's do another one. So give me 10 words that start with letter N.
New.
Noble.
Novel.
Narration.
Nectar.
Oh, do it. Okay. Please help me put your hands together for them. Thank you so much for trying. Thank you for trying. You can please go back to your seat. You can give them to me. Thank you. All right. So concentration, we played that because I want your total concentration as we go on to the next panel, which will begin very shortly. Have you posted your pictures on Twitter? Have you posted? Tim, do we have pictures? Can you see the pictures online? Or is the guys outside? Have you posted your pictures? Have you collected someone's phone number? You haven't? Please get the phone number, get their social media handles. We're going on to the next session very soon. And don't worry, as usual, it will be packed and totally engaging. So let's keep our eyes up here. To join the conversation, remember the hashtag is on the screen. It's the hashtag PS Health NG. PS 4 Health NG. PS number 4 Health NG. All right. Are we ready for the next panel? Okay. It appears we are. We will start the next panel in a bit, and once we're ready for that, our speakers will be back up. All those who are still outside, can you please come in? Can you please come in so that we can get the next panel started? We have our speakers getting ready. They're being mic'd up for their session. Okay. Are we ready? All right, I believe we are. Chibuke, are you coming up here? I thought you were coming to me. I was expecting that. Okay, while we wait. Hello? Can you please give me my phone on that table? Right here, beside the teacup. Yes, that one. Thank you. Okay, so while we're waiting for the next panel to get mic'd up and ready to come up here, you know, I love mathematics. It's funny that I never loved it in secondary school, but because I like money, now I love numbers. So we're going to play a quick mathematical game. Are you ready? Where are your phones? Please keep your phones on your table. I don't want you using your calculators. Just tell me the answer as quickly as you can. No, some of you are actually opening your calculators. Okay. Are you ready? 8 times 9. Come on now. Are you ready? Are you ready now? 8 times 9 times 3 What did you say? Divided by 3? God bless you. Whatever your answer was, my final answer must be correct. That's my own. Let's start again. 8 times 9 times 3 divided by 3 plus 7 plus 52. What? Yay! Please put your hands together. 131. Did you get your answer correctly? Some of you did not even try at all. You did not try at all. So let's do another one for those who did not try. Let's use smaller numbers. Are you ready? Are you ready? What is 6 times 33? 90 what? It can't be 90 something now. It has to be 100 and something. 198. Well done. We're ready for our next panel session. Please put your hands together for my co-host, Chibike.
Thank you, Wemimo. And thanks everyone for making your way back for this exciting session. It will be moderated by Ekenem Isiche, CEO of ACO Associates. Please make your way to the stage and introduce your panelists. The session will be focusing on private sector partnerships and collaboration to sustain the diaspora brain gain. Thank you.
See? Good afternoon, everyone. The energy. Good afternoon, everyone. Good afternoon. Good, good. At least you're awake now. Let me ask a question. How many people have applied to go and study abroad or leave this country? I'm seeing a few hands that are like this. I see some hands in the back. Thank you for being honest. How many of you know someone who has gone abroad to pursue their studies, medical studies? How many of you? How many doctors do you know that have gone? And nurses? Let me see your hands if you know somebody. I'll start off with this story. We had an emergency in the family, and so we took a family member of ours to the hospital. It was an emergency. When we got to the hospital, we saw the nurse that was there. And so we asked the nurse after a while, why haven't they looked at our family member? And she had an attitude. So I asked her a question. I said, sorry, madam, as you know, we have an emergency, but I'm just wondering why we're being treated like this. And she just said, well, anyway, whatever it is, I'm leaving in a month, so that's it. So she had the attitude that she was leaving in a month's time. So she didn't bother anymore. Unfortunately, we have a lot of our really great people who have left this country and have gone abroad to pursue their studies. And nothing wrong with that. But because of that, we have a shortage of human resources in the medical space. What that means is that if you have an emergency today, do you know the doctor that you can reach out to? Do you know the nurse that's going to treat you? Are you confident in that nurse treating you? I've given blood before. And when I gave blood for my family member, it was an NYSC student that was managing. She was just playing with my nerves. She was playing with my nerves because she didn't know what she was doing. So we have a problem. And I say this because you can be on the road today in Ogun, Borno, Oyo. God forbid if anything happens to you. What's the plan? Are you confident in the doctor or nurse that is going to treat you? Today we're going to be looking at a topic that is really important. which is around this brain drain. The fact that people are leaving the country. The fact that by this time next year, maybe half the people in this room will not be here. What does that really mean for us as Nigerians? How do we begin to hone into those folks that are out there to come back and add value, or even add value from there? Why would someone like the current Minister of Health, Dr. Ali Pate, leave his high-paying job or proposal to go into Gavi and come back to Nigeria? There's a reason. So today, my panelists have extensive, amazing backgrounds in the work they are doing. These are the few that are committed. These are the few that have chosen to stay. I ask you to lend your ears to hear them, because what they'll be sharing today is how do we leverage on this important skill gap that we're seeing. I left Kaduna yesterday by road. We're seeing a PHC somewhere in Kaduna. What we saw there, then go by road, then get to Abuja, then get a flight, then come to this program. If you're in the advocacy space, you're in the health space, you need to think differently. You can't be there trying to tell people what to do here and not understand what's really happening here. And that skill at this level is missing. So I'm going to call up some amazing people who are doing some amazing work. Let me start off, and please, as I call them, please give them a warm round of applause, because these are the committed, these are the few, these are the ones that have decided to stay, that decided to also hone in on this skill gap. So the first one I want to call is the Country Director for Farm Access, Nigeria, Dr. Njide Ndili. Please clap. Energy in the room, energy. Energy in the room, energy. Energy in the room. I like the energy. Let's keep that energy up. The second one is the one that sees everything going on, because he's the president of the Nigerian Medical Students Association. So now then, they see everything will happen. So please give a one more applause to Mr. Ejim Egba Clement. Energy in the room. Energy in the room. We'll have to hold on to him because he might not see him next year. So let's hold on to him. And then the next person in the room is the Executive Medical Director for Regions Healthcare, Dr. Benjamin Ayawo. Please, energy in the room, clap, energy in the room. Thank you. And the last person is the Managing Partner for Health Ethics and Law Consulting, Professor Chiluchi. Oh yeah. Yeah, Luchi. Yeah, sorry. Professor Chiluchi, I'm so sorry. Please clap for her, please. Hi. Sorry about that. Great. So, this is the framework for this discussion. Because of the time we have, they will each give a 5-minute, no more than 5 minutes, please, presentation. The reason why I'm doing that is so that you can ask questions. Well, this is meant to be an interactive session, so you can ask questions, burning questions that you have about, even if I leave, what kind of value can I have? So I know you have burning questions, and they are here to answer that. So please, leave your phones, leave WhatsApp, leave Instagram. They will be there forever. This is happening live. So let's tune in and let's listen to these wonderful participants as they kick off. So we'll start off by the first presentation by, who should I call up first? Drum roll. Okay, grab the mic already. So, Dr. Njide Ndili, please go. You have the mic. The floor is yours. 5 minutes.
5 minutes is quite short, but so am I allowed to make any presentations?
Yes.
Yeah.
So,
okay,
media, if you can please. Okay,
yeah.
great.
So, good afternoon, everyone. Normally, I would say we shouldn't break at all for lunch, otherwise everybody leaves the room. But let me start by saying that people like myself are too old to run. So we're not going anywhere. In fact, if anything, we should be encouraging our fellows outside the country to come back because there are huge opportunities. So the first thing I want to say is that, and I don't know if you can go to the next slide, it's important to understand the ecosystem, in the healthcare ecosystem, because it's extremely complex. There are a wide variety of stakeholders, and one without the other, there's bound to be service failure. Unfortunately, I've been listening to all the panels, and different speakers often speak from a specific pillar, and we are one of the fortunate ones to see the entire ecosystem and actually try to intervene in the entire ecosystem. And we do this by partnerships. We are funded, for those who don't know PharmAccess, we are funded by the Ministry of Foreign Affairs of the Kingdom of the Netherlands. And our aim is to help to improve the healthcare system, but focusing on the private sector. So our whole idea is start private and grow public. The reason being that innovation starts in the private sector, but you cannot scale and sustain if you don't involve the government, which is why there's a need for public-private integration, not even partnership. We need to work together, but understanding the different pillars around which the healthcare system functions. Unfortunately, the slides are not very visible, so I'll talk to it very quickly and hopefully within 5 minutes. I think we've talked about this. I was very impressed with the Minister, Mohamed Pate. In fact, he gave me a lot of hope with the way he structured the pillars around which he intends to work. But basically, re-emphasizing that private sector brings innovation, brings new ideas, they bring the funding, performance management, and so on. But yet, government has a key role in the purchasing mechanism. So if you go to the next slide, I think what I want to just quickly touch on is a study that we had done. I think that understanding where private sector can come in, especially those in the diaspora, which is now brain gain, is where are the opportunities? I heard the fact that healthcare is a business. Indeed, it is a business. But we need to understand how it's structured, where to intervene, and how to bring the funding into the country. When you go around talking to quite a number of the diasporans, they're very interested to come back to Nigeria and to contribute, but they don't know how. Which is why the Healthcare Federation has, for those who don't know, is the advocacy body for private sector to get involved in improving the healthcare system. So what we're doing is actually engaging them and showing them opportunities in areas where they can actually come and invest and be part of the rebuilding of our healthcare system. So we did a fantastic job in trying to aggregate areas of funding, areas of opportunities, and it's all in this report, which is a health market study report, which was funded by the Embassy of the Kingdom of the Netherlands. There's soft copies, and it's free everywhere because we really want people to invest. Next slide. We also went further to actually organize webinars, in-depth webinars, showing cash flows, that there's real money to be made in investing, especially those bringing their money back from overseas. So this is just to show you a snapshot. We went into PPPs at the primary healthcare level. We went into vaccine production, pharmaceutical, supply chain management, ICT, also very critical. That's another area where, you talk about a country of over 200 million people. And the role of NHIA is to provide health insurance, but yet they don't have a domain name. The emails are still in the names of Hotmail and Google and so on. So there are basic infrastructural issues that need to be addressed. And I can tell you that the knowledge, even though there are some here, there are huge opportunities for those coming from outside the country to support the system. Next slide. Now, we talked about governance. And again, I must say that if I look around the room, it's all mostly private sector. The government have left the room. Is there any government official still here? Okay, well, you're from Sierra Leone. But that is the problem. We are talking to ourselves. We are speaking to the converted. I think that if there is going to be any change in our healthcare system, the government needs to stay in the room and dialogue with the private sector. Because right now we're talking to ourselves. So it's unfortunate, I see it at so many conferences that I go to, that we end up not achieving much because somehow the government gives up the perception that they couldn't be bothered. And we need to change that, unfortunately. So anyway, going back to my slide is, just to show real quick some of the work that we're doing. And I won't go into detail because I only have 5 minutes. But this is where, we try to work with the regulator, because the government is regulating private sector, and private sector has more capacity than government in most cases. So they're regulating you to death. Sometimes their policies don't help you scale. And if you're going to attract diaspora funding, they need to be sure that when they invest, that they are able to get their monies back. So the enabling environment, you heard Dr. Idris talk about it. The access to finance he was talking about was, we actually started it in Lagos and Delta. In Lagos, it was killed because, it sounded like sharing money, access to finance. So it didn't move very quickly. But if you go to the next slide, you see some traction that we're gaining. For example, we have signed an MOU with the NHIA, who is regulating the supply side. And the reason why I bring this up is because currently, I know that they have over 7,000 BHCPF facilities. And we as Farm Access, the Safe Care team, we're probably about seven staff. So what does that mean? We're looking for partners, both local and from the diaspora. And brain gain doesn't really have to be from outside the country coming in. It could be people that are building up their knowledge from a different industry to another, just to help develop our healthcare system. So in that sense, we're currently partnering with Healthcare Federation, where Healthcare Federation will reach out to some of its members for those who are interested in licensing the Safe Care model to scale. Fola, who has just left the room, we've also engaged SQHN, because really the whole idea is how can we get more partners to who we can support to scale some of our initiatives so that the healthcare system is strengthened. Next slide. Now this is talking about the Medical Credit Fund. Not only do we do the actual implementation where we are testing innovation and seeing how it works, but sometimes we actually give you the money to do it. I have one of the directors of the Medical Credit Fund in the room. The Medical Credit Fund is over $40 million of catalytic funding, which really, it's an impact fund which we have to get back, but it's to support the growth of the healthcare sector by investing predominantly in SMEs. So within the next couple of months, we should start a digital loan because of our partnership with Evolve Credit, where we're able to give out loans without collateral and just by looking at your working capital and transaction. But this is just to give you an idea of what is going on. There's so much that I can't say in 5 minutes, but the whole idea is that there are resources, there are opportunities for people outside the country to participate and support. All they need is the guarantee that their investments will be returned at the right time and with some added value. Next slide. Then just real quick, this is just a series of pictures talking about the access to finance which Dr. Idris talked about. This is the one in Delta State, which has become quite famous. Where, as you know, we have over 30,000 primary healthcare centers, of which less than 20% are fully functional. So we're saying, can we bring in private sector, not just those in Nigeria, but those in the diaspora that want to run chains of hospitals to come and take them over. So we started out with 15, and it has shown significant, when I mean significant, impact. We've done an impact evaluation. The report is also available, soft copy, hard copy. Most important impact, I have to say, is the maternal mortality in the 15 clinics where we have taken over. There has been 0 maternal deaths. So it's amazing. Again, it just shows that if you put in the right structure, you put in the right people, processes, equipment, that you will get the right outcomes. And the reason being, simple thing, market women go to the market, they're pregnant, because there are no lights in the PHCs, they wait till the end of the day, when they finished their market to go to the clinic, and by then there's no light in the clinic, what happens? They go home and there's an adverse event. But with private sector, it's 24/7. You go in, and some of the private sector participants, operators are in the room. Shegu, I don't know if you're here. Pelham Memorial, Shegu is over there. These are Lagos-based, but they've gone to Delta State to run PHCs. So if you think about it as franchise, like McDonald's, where you have the system, the processes, the equipment, the technology for primary healthcare. Why not? You can run 10, 15. That's how systems are. Kaiser, St. Elizabeth, and so on overseas. So really, how can we bring in private sector to help take over some of these? Next slide. Just to, this is another example. The one in the middle, I'll focus on the Health Connect, is one that we're currently testing. And the consultant who is actually working on this innovation is based in the UK. And what it is we are sending billions of dollars back to Nigeria. Some of them are being sent because your relatives are asking for money for medical bills. And we're saying you can channel it through this platform directly into a health insurance program so that really they pay for it directly and the patient or the relative is covered. That way, they don't divert it to buying a car and so on and so forth. So we're currently testing that. And the whole idea is channeling some of those fundings directly into supporting health insurance in Nigeria. So at some point, you'll probably hear about it. It's called, we're changing the modalities, but it's going to be called Health Remit. Next slide, which is just my last slide. But I must say that there's so much opportunities in the market. There's so much to be done, and I think that without private sector supporting government, it will be very difficult to achieve universal health coverage. I haven't even touched on technology, digital technology and what it can do. Every one of you has a mobile phone. In other parts of the country, like Kenya, where we work, we're using that phone to aggregate funding, which you use to pay into a health wallet, so it's specifically for healthcare. So there's a lot going on. There's collaboration that could be done with those outside who have experience and the money, and to be able to bring it back here. But the reason why I have this last slide up here is that there's a lot of advocacy that needs to happen. I know Nigeria Health Watch is very good at that, but a lot more needs to happen. And we're most proud of the one in the middle, which was recently published by the World Economic Forum, and is focused on Lagos. The fact that Lagos now is reimbursing its providers on a differential rate based on their level of quality. So you're enrolled in the Safe Care level. If you're Safe Care level 4 or 5, which means that you're a really good provider, then you're paid much higher than the others. So it's aspirational for other providers to try to improve the quality of care. So again, I think I'll end here, knowing that I've gone over my 5 minutes. But hopefully, I think during the Q&A, maybe I can answer some more questions. But so thank you so much for the time.
Okay, great. Thank you so much, Dr. Njide. Our very next speaker will be Mr. Ejim Egba Clements, who is the president of the Nigerian Medical Students Association. So you can quickly share your perspective in 5 minutes, no later than 5 minutes. And then we really want to hear from you and how how students are thinking along these lines.
First and foremost, I would like to, in a very special way, thank Vivian for recognizing the Medical Students Association in Nigeria. It's a great work the Nigerian Health Watch has been doing over the years. Recognizing medical students as the conference is, Future of Health Conference. It underscores the fact that the future of the health sector in Nigeria lies with the medical students. And I can tell you for a fact that the future is bright. A lot of us, yes, a lot of us are not looking at living. A lot of us actually, we are looking at staying back, right? Yes. Yes. Earlier this year, I was privileged to make a presentation here in Lagos, together with the immediate past Commissioner of Health, Dr. Jide Idris. In fact, he was the one that invited me for that conference, and it was around brain drain. So when I was approached for this conference, and I saw that it was a bit different, people are beginning to understand that, yes, we can actually convert the brain drain into brain gain, and that will do the Nigerian health sector a lot of good. So thank you very much for this opportunity. I've made a presentation, but for want of time, the moderator is already warning me. I would just like to go through the presentation very briefly. Please, next slide. We understand that the Nigerian health sector currently, there's a lot of opportunities, especially for the private sector. Currently, the private sector in Nigeria contributes only around 26% of the service delivery to the health sector. What that means is that there's a lot of opportunities that is abound in the health sector in Nigeria. We also understand the fact that there is no investor that wants to come and put his or her money into a system that is not certain of getting a return. Having said that, we also understand that there are players currently in the industry that are doing excellently well. They've gone out, they've acquired these skills, and they are back to the country. One of such persons is just sitting right before me, Dr. Shita Abe. They are doing wonderful job in Duchess International Hospital. And there are a lot of other people like that out there. So the health sector in Nigeria is green. The opportunities are there. All we need to do is to find a way how to harness some of these opportunities. And one of such ways is what we are doing now. Collaborations and partnership between not just the public sector and the private sector now, that even within the private sector, sectoral collaboration, an individual can want to collaborate with another individual that he feels or she feels has a better expertise in this field. And then you guys can come up together and put up a system that will solve the problem in the health sector in Nigeria. As medical students in Nigeria, we are doing a lot. One of the things we are doing is to stimulate the spirit and the culture of research amongst our members. Recently, I was privileged to sign an MOU with future African scientists. We are currently trying to see how we can establish research hubs across the 6 geopolitical zones in Nigeria. These things don't come easily. They are cost effective. But we are privileged to have these people have us share our ideas with them and tell them that yes, we want to stimulate the spirit of and the culture of research amongst our members. We understand that if that is done, when a student graduates, by the way, by the special grace of God, in no distant time, a couple of months from now, I'll be leaving medical school. When we finish, and we have been given this opportunity to go into research, right from medical school. When we leave the system, we will not want to leave the system that has given us so much. So those are some of the things we are doing to see that we captivate our students and imbibe that spirit of patriotism in them to stay back after medical school. Even if they want to go, it's going to be transient, right? They just go out, gather some skills, learn new expertise, and then they return back home and then make contributions to the health sector in Nigeria. Also, there's a challenge we recently launched. Luckily for us, the Oni of Ife is our grand patron, and it's a foundation he runs. So we are working with the foundation currently to carry out a health innovation challenge for medical students, not just in Nigeria, but in Africa as a whole. This health innovation challenge has been on for a couple of weeks now. Specifically, what we asked in that challenge is, you look around your community, your immediate community as a medical student, if it's your teaching hospital, if it's your community where you live, identify a health-related problem in that community, and then provide a solution to that problem, and then you pitch your idea. You know, this idea is going to be reviewed by a panel of judges objectively, and then the best ideas will be given grant to execute those ideas that they've pitched. And it will surprise you to know the tons of applications that we received from medical students, not just in Nigeria, but across Africa. And these are brilliant ideas, but over the years, these people have not been given the opportunity to showcase some of these things. And that is what we're talking about in terms of innovation and technology in the field of health sector. We are doing a lot. And I want to use this avenue to call on well-meaning Nigerians that are here, corporate bodies that are here, that as medical students, we're actually large, over 75,000 medical students, both here in Nigeria and in diaspora, that encompass the body medical, NIMSA in Nigeria. We are doing a lot, and we are calling on well-meaning Nigerians to look into the plight of medical students in Nigeria. Currently, the situation in the country has made a lot of universities in Nigeria increase, some to the extent of 1,000% increase in school fees for medical students. Before now, I used to pay 45,000 naira, but the universities have made it that the school fees, just the school fees for a session is around 250, and that is just for my center, which is a federal university. There are some universities that are state-owned that are paying as high as 2 million naira, and that is so much that students are crying every now and then. So if we can create some sort of a pool of funds for them, this will form some sort of bonds with these students. You cannot have gotten such privilege and then you train here, and after your training you want to leave. So I'm using this opportunity to call on everyone to look into the plight of medical students in Nigeria. We are doing a lot, and then with collaboration, there's so much more we can do and we can achieve. I look forward to a very constructive and a very wonderful deliberation on the course of this panel discussion. There's a lot I'd wanted to say, but because the moderator is already beckoning on me to stop, I'd want to stop at this point. Then, during the course of the panel discussion, I'll throw more light on some of the ideas. Thank you very much.
Thank you so much, Mr. Ejimegba Clement. Thanks for your comments, and it's good to get the perspective from what students are thinking. And we'll tell you congratulations in advance to your graduation coming up very soon. Our next speaker is Dr. Benjamin Ayaun, the Executive Medical Director for Regions Healthcare. Please give him a round of applause when he comes up to the stage.
Slide, please.
And if you can put the slides up, fantastic.
Good afternoon, everybody. I'm very pleased to have been invited to talk here because I'm an example of that brain gain you talk about. I went to medical school here in Nigeria, left Nigeria in 1995 to the United States, ultimately did my residencies and fellowships. I'm triple board certified, worked my way ultimately to become the chairman of neurosciences in that beautiful hospital in Winston-Salem. And in 2016, I made an informed decision I have to go back to Nigeria. I tell you, my CEO was very worried and wondered why I wanted to go back to Nigeria. But that's what I wanted to do at that time, because I had made myself a promise that if I have to come back to Nigeria, I want to do that under 50. And I did that at the age of 49.
Wow, nice.
We came down to Nigeria to establish a neuroscience institute in Owerri, Imo State. We did that on purpose. It was a purpose-built hospital, but with ideas to expand. We started doing the things we knew best to do, which was neuroscience and neurology mainly, and neurosurgery. But we knew that soon after we were going to add on that. And what we have done over the years is that today we have a multi-specialty hospital and has transformed from Regions Stroke and Neuroscience Hospital to Regions Healthcare Hospitals and Specialist Clinic that has most of those clinics that you see there today. So how have we been able to do that? We've been able to do that by collaborating both with my diaspora colleagues in the United States and UK, as well as doctors who are trained here. What you see there happening there is a clipping of aneurysm. Before we started this, there were probably about 2, 3, 4 centers in the country that could do this. There was none in the Southeast. Today, we can be able to clip an aneurysm should you rupture an aneurysm anywhere in the Southeast and South-South. It was not present when I came, and it bothered me so much because I used to wonder, as somebody who was running a neuroscience hospital, if I ruptured an aneurysm and died, it would be very shameful. This collaboration has made it possible. There are several other collaborations who have been backed over the years as well. This is somebody who has a knee replacement surgery. We have done this by collaborating with also diasporas who have also returned to Nigeria. This was done by one of our doctors, Dr. Ike, who runs a Nike Orthopedic Hospital in Enugu. Somebody had mentioned that collaboration is not just with people who live abroad, but also people who have returned and people who are also local here. We also offer an open heart surgery program. Who you see there is Dr. Nzewi. Dr. Nzewi is, he's now retired, but still resides in Ireland. And he does open heart surgery. And now he has brought in his colleagues. You can see the guy there came from India, from Apollo University Hospital, to work with us to support our pediatric and adult open heart surgeries. And how do you do this? You do this by creating an enabling environment for the returnees to be able to return. Somebody had just said, a lot of people want to come back, but are afraid of coming back. And why are they afraid of coming back? For different reasons. Sometimes they don't have the finance, sometimes they don't know where to start. So you create an enabling environment and help them to come back. You also create an enabling environment to make people stay. This program is a nephrology program that you see there. And I'm very proud to say that there is a young doctor, her name is a young consultant nephrologist, Dr. Adam. At the time I met Dr. Adam was trying to jump out from the country to UK. And I sat her down and talked to her about several opportunities that she can have in Nigeria. And today, Dr. Adam is running a very highly active nephrology clinic in our place that supports both critical care and what we call CRRT. There are only about 4 hospitals that offer this in this country. We have done more by putting also initiatives, like I said, attracting diaspora trained doctors. We run every Thursday now in our hospital an epilepsy clinic. This epilepsy clinic is a free epilepsy clinic that is supported by a foundation I own, West Atlantic Brain and Stroke Foundation in the United States, that supplies free medications to the doctors. I'm a neurologist, but I'm actually a vascular neurologist. I'm not an epilepsy specialist. So through telemedicine, we have been able to engage a professor of neurology and neurosurgery who's an epilepsy specialist at Virginia Tech University School of Medicine, who stays on video every Thursday to be able to make that clinic possible. So again, major problems we have will be medical financing, insecurity, and to create soft landing for the doctors. We have 2 soft landings we're about to create now. One, if some of you were actually watching on your social media about 3 weeks ago, 1 month ago, there was a man who had Parkinson's who had gone to Turkey to get a surgery, deep brain stimulation surgery to be done. I don't do that, but I have doctors who do that in the United States, and we're in the process of trying to bring down those tools and enable them to come in here to do it. But part of that agreement is that within a 5-year period, they will be able to transfer that technology to locals here who can be able to continue to do that after they've gone back. So hopefully we're looking out for these kinds of things to happen. We're also looking out to do kidney transplantation with Dr. Obi Ekwenna, who is also a professor of transplant surgery at Toledo University. So we are able to do these things because we have created soft landing for these doctors to be able to come in and do this. But they continue to encounter problems, and therefore, how can we work with government to make this possible? So an Indian doctor comes, and which is fine to work in Nigeria. He's offered a temporary license for a year or two, very easy for him to actually get. A Nigerian doctor who graduated in 1990 and had been out there comes back, and you want him to go back and retroactively pay the amount of licensing fee he's supposed to have paid over the years from 1990. Meanwhile, this guy was working abroad. How can government make this possible? One of the ways government can make this easier is to create ways to allow these people obtain their license. Anybody who, for instance, knows people who are United States citizens like me, we pay double taxes. As a US citizen, anywhere you are in the world, if you work, you are supposed to pay and remit taxes to the United States. So when these people come work here, we still tax them down here locally, and then they kind of go back to America and get taxed. So you can see that some of them may not necessarily want to come here and work unless we give them incentives such as, say, tax breaks when they come here to provide services. We can engage them by using telemedicine, which we have used very successfully, and again, foster true collaboration. You know, I say true collaboration because somebody has said in one of the earlier discussions about mandating public hospitals to allow these collaborations and PPPs to work. And then somebody said, well, you cannot mandate them. Well, if you don't mandate them, they're not going to do it. And if anybody here has trained abroad and gone to a public hospital, and I'm saying it here, you will see how very difficult they make it difficult for you to assimilate and become one of them. You know, the stories abound. But government has to figure out a way to help us come into the country and provide services, understanding that after 20, 30 years of staying abroad, the way you think through things, your problem-solving capability is very different. There's nothing wrong with our colleagues who are here in Nigeria, but the way we look at things, the way we assess things is very different. And if you're trying to force that person through that thought process that is very different from what they have done over the past 3 decades, it's a little bit difficult. And therefore, figure out a way to create rooms to allow us to operate within the system while rendering services and improving healthcare as well. Finally, I would like to highlight specific areas where we have rendered service that has helped the people. So this is one of the patients, some of the patients from our cardiac program. Remember, I told you this hospital is located in Owerri. Clearly, you can see those people who are from the north. We get patients from Lagos, we get patients from Abuja, we get patients from Kano, and I believe these folks here are from Gombe. What has that done? It has helped us provide service here for them in Nigeria. It has helped us retain the foreign exchange that they probably could have used to go abroad to get surgeries here in Nigeria. I mean, the collaboration continues, and I cannot even begin to name how this has helped to stem the tide of medical tourism and improve them here. What you see here is what I do with FCC here in Lagos, First Cardiology Consultant. If you have a stroke and go to First Cardiology Consultant today, they will call me from Owerri, and through telemedicine, I will take care of you. The same thing happens at Palion Clinic, and many more other hospitals were trying to sign up. So like the president of the Medical Student Association said, collaboration is not just with people outside, it's also amongst our people here. Again, collaboration is not just with people outside, but also amongst our people here. And you can recognize some faces here. That is Sheyi, and that is the guy from Iraq here. And all of these things are diasporans, and some of the professors who also work here in Nigeria that we meet from time to time and exchange ideas and see how we can be able to leverage our knowledge in order to help them. I thank you again for listening to me.
Thank you so much, Dr. Benjamin. Once again, we're really short on time, so Professor Cheluchi, the floor is over to you. Please, less than 5 minutes. Thank you.
Okay.
Did I do 5 minutes?
Good afternoon, everybody. By this time, you're probably tired already. The good thing about being the last person is that practically everybody would have said everything you want to say. But it's all right. I am not a medical person. I'm not a medical doctor, although that is what my mother prayed for me to be. But I am a lawyer. I run a law firm called Health Ethics and Law Consulting. We work extensively and have done so over the past 15 years in the health space, working for all kinds of clients, big and small, and for governments, both within and outside Nigeria. So that is the experience that I bring to these matters. I also do quite a bit of work in the migration space. So I led the technical drafting of Nigeria's national diaspora policy a few years ago. We've also had the privilege to do some work on the legal work on the Presidential Health Reform Committee, which presented a report at the end of the last administration, and I'm going to say one or two things about that report and so on. And we've had the privilege also to work with PISHAN on its fantastic initiative, the Adopt a Primary Healthcare Facility. We did the legal strategy and regulatory framework for that initiative. And so across all these experiences, I have really identified a few things that have puzzled me, right, about how we are going about managing our situation with what we like to call brain drain and the migration of healthcare professionals from Nigeria. Everybody agrees that it is a critical issue, that we have a huge challenge on our hands. We have recently been put on the red list under the WHO Code of Practice, International Recruitment of Health Professionals, which is the basis for the WHO Health Workforce Support and Safeguards List. So in 2023, we're now in the red list along with countries that are way smaller than we are. So I found it very interesting when he mentioned that we're paying 45,000 naira and so on. So you can see that there's some complexities there, right? Basically what it means is that we're training healthcare professionals for the world. And it is not as if we have enough for ourselves. And so the question is always for me, how is it possible that we cannot come up with solutions that work? And as I listen to the panelists, you know, there are obviously solutions. What I don't understand, and that's the first thing I want to say. So I want to say two things. One about policy coherence and policy implementation, and the other about storytelling. Okay. So with policy coherence, I just mentioned, of course, that I helped to draft the national diaspora policy. And I remember that, you know, when we were doing that, we had, you know, members of MANTAG, other, you know, entities come in and make some suggestions. Since that time, some of the conversations that we have had, for example, around tax incentives, you know, and so on, have not yet yielded any fruit. So does that mean that we are taking ourselves seriously or not? Very quickly, we've talked also about managed migration. We recognize that people are going to leave regardless of, you know, how wonderful things are. So if you go to other countries, other parts of the world, people leave. People leave the US to other places, surprisingly. People leave Canada to the US, and so on. But there is always some kind of framework within which these things are done, right? What is our framework? What is our policy framework? So I've always wondered about this. As serious as our situation is, how come we don't have core policy around health worker migration? So as if, you know, somebody heard my thoughts, we've now started talking about a policy. I don't know how many people in the room know that there is currently an ongoing process to develop such a policy. I was at that meeting a while ago, and what interested me was how many people were missing in the room. The private sector, members of these diaspora organizations that I've mentioned, and interestingly also people from the migration space. What you will likely have at the end of the day is the National Diaspora Policy saying one thing, the National Migration Policy saying another thing, and the Healthcare Worker Migration Policy that we're developing saying something different. And of course, some of these ideas have been around. How do we bring them together? How do we ensure that that policy that we are putting in place really supports us? A few months ago, when we were put on the red list, the question that many people like the president were asking was, does that mean we cannot go to the UK anymore? And the question we should ask ourselves, I think, as Nigeria is, what is our own stand on being on the red list? What should that mean to us? Why don't we have an agreement, a bilateral agreement with all these countries, to the destination countries for most of our healthcare practitioners? Why don't we have such engagements with them to ensure that they are, that we are getting something in return? If people are paying 45,000 naira, 110,000 naira, and this may not be small money for people, but we know that in the wider context of health care training, that is minimal. Why are we willing to give up so much and not make any effort to get anything? So those are my questions. And I think that we need to really begin to think in terms of mining conversations that have happened over the past few years. If you look at that report of the Presidential Health Reform Committee, this was something they considered extensively. They went into a lot of detail around the tax incentives, around bringing private sector organizations into training and working with regulatory bodies to ensure that we can have that kind of training so that we have more than enough. Because the problem is not necessarily people migrating, is that we don't have enough, and so on. We've talked about other kinds of incentives, but even issues around telemedicine, telehealth, digital health, whatever you call it, is becoming big. I'm so glad that Dr. Anyanwu went into how we're using that extensively. We have many clients that work in that space and are really looking to leverage diasporan healthcare providers in providing excellent care. Can we look at all these things as a holistic policy, provide a holistic policy and enabling environment that encourages people to return home? The second thing I want to talk about is about storytelling. So if you work in this space, most of what we hear is negative. So Dr. Anyanwu took on what I was going to say, because especially for those of us who live in Lagos, who have access to Evercare, Uracare, First Cardiologist, and the rest of them, you see how many diasporans come back. My father's urologist works here in Nigeria in different, in fact, he goes to different facilities. And when I asked him, I said, why are you here? He said, I spent 25 years there. And I believe that I'm much more needed here. So it's not about the money. I really want to work here. How do we mine that? When we see those examples, why aren't we using that also, not just in the private sector, but in the public sector? What will it take for us to use those kinds of incentives in the public sector? We have Dr. Odira Nwankwo, for example, who runs a project called the Nigeria Pediatric ICU Project. He brings back pediatric equipment for working in the ICU, and has worked with hospitals in the Southeast. And they have a strong partnership where they teach doctors there how to use the equipment. They support them. They come in from time to time, and so on. how do we bring all of these into a cohesive whole? I think that is my question. I think we should look at these things as both challenges, but also really opportunities. As a storyteller, and knowing all the work that Nigeria Health Watch does in this space, I think that we need to tell more stories about what is going on with the diaspora, what they bring to the table. I think with a new administration in place, that this is the time to tell those stories, that this is the time, you know, to sit with the minister. Unfortunately, I came in late, so I missed his speech. But this is the time to sit with the minister, because some of the stories that we have heard before, you know, I don't know if this is a good place to say that, but you know, where you're telling doctors to, you know, doctors can be farmers and things like that. We need to change that narrative. People know me in other spaces as a storyteller, and I know that stories change minds. So I would suggest that we need to create that enabling environment. We need to begin to participate in the conversations that go on around policy, but we also need to tell stories about the good things that are happening with private sector engagement, with diaspora engagement, and we need to engage much more closely with the diaspora in order to create the kind of healthcare system that we can all be proud of. Thank you.
Okay, it's working. Okay, great. Don't worry, I'll just stand because we've been sitting down for a while. We've heard our 4 dynamic speakers talk about this brain drain and brain gap opportunity. And I want to steer this conversation back into the forward-thinking, into a forward-thinking mode. How do we begin to think about what we can do starting from now? Yes, we know about the government might not be in the room and some other actors, but in our little spheres, I know you all can do something about it, and you're all already doing something about that. And so, because I'm saying that because I lived abroad, I schooled abroad, I worked abroad, and I'm back in Nigeria. That's the truth. And I've been back for 10 years, and the truth is that I will not be doing what I'm doing now if I did not decide to come back. I'm a partner in a health advisory firm. We're doing work in Lagos, Kano, Kaduna, national level. I'm working with different development partners. But I would not be able to do that if we didn't come back. And the truth about it is that the impact we're making today, I don't think we would have made it if we were in the UK or the US. So my first question to everyone, and please take advantage of the Menti to put your questions there. They're here for us to listen to, but I want you to really ask focused questions on how, what steps. So if I were to ask you all, just a really quick question. If there are people in the room that are probably wondering, they have family members abroad, there are people listening online, can you just in 1 minute just tell us, advise them, what steps can they take right now if they're thinking about coming back home to make an impact? What critical steps can they do right now? So let me start with you, Professor. What advice would you give to them?
So those who are thinking of coming back?
Yes. I want to add value, especially in our medical system.
I would say come back because you're going to make a difference. I would say you don't have to wait for everything to be perfect. We have people who have returned and are helping to reshape the system. Thank you, Dr. Anyanwu and the rest. Okay,
yes,
sorry.
I was going to say.
Okay. And that there's more than enough room for you to be part of shaping policy, for you to be part of shaping the environment. You know, we have problems, obviously. We have our problems, but those problems will not be solved without each one of us. People abroad, everybody abroad has somebody that they care about that live here. So I think that should be one of the incentives. Obviously, I think there are things that government should do on that side as well. But if you're asking me about the people that are abroad, we have examples, and that's why I talk about storytelling so much. your story, for example, is a story that needs to be much more out there. The younger people don't hear that. All they hear is everybody's taking PLAB, everybody's in the UK, and so on. They don't hear all these other stories about those who have gone and who have come back or who have stayed. And those are stories I think that we need to get out there.
Thank you so much. Dr. Njide, you talked about the product that you plan to release that's supposed to be helping out those in diaspora that maybe want to support the medical system here through taking care of their medical bills and all. When is that product coming out? What should we expect from it? And how soon can people here tell their folks abroad that they can come on your platform?
Well, it's still in development, which is something I have to say. But let me go back to answer the same question you asked the rest of the panelists. We have the Healthcare Federation of Nigeria. I think that is becoming more and more recognized as a body that can make the connection between those in the diaspora and those who are here. Of course, coming back is always very scary and traumatic. I too am a returnee. But I came back 20 years ago. The kind of impact that I'm making now, I was just a number in a company that had 4,000 people. In fact, when I forget my ID card, they won't let me into the building. But here you see the direct impact of what you're doing. And same as you, I'm only able to do what I'm doing because I have a knowledge of a better system, which is what we need to bring back. So the Healthcare Federation serves as a body that can connect those who are looking to come back with those who are already established here. We can connect you with government. In fact, currently we're trying to develop a database of all the private sector organizations in Nigeria into a handbook, although we're still looking for funding to be able to do that, so that it's easier to make the connection. I think that is one key action point I can give. And I think if you go to the website, our information is there. But talking about...
so what's the website? In case
it's www.hfnnigeria.org, if I'm correct. Just type in Healthcare Federation of Nigeria, it will pop up. And by the way, this is a movement now that is being supported by also USAID, recognizing that it's not just Nigeria that has this problem. All of West Africa has the same problem in terms of system failure, folks in the diaspora. So they are funding us to come together. So there's now West Africa Healthcare Federation, there's East Africa Healthcare Federation, just pretty much the same thing. How can you bring back a brilliant diaspora to contribute through either physically or through digital, telemedicine and so on and so forth. So I think that's very key.
One second. Just hold our thoughts. Dr. Anyanwu, there are people that are listening online and they're thinking, great story, this is amazing what you're doing. So how can we partner with you? I mean, a doctor in Ireland that's listening to this conversation and I don't even know where to start. So how can I start?
Well, one, let me answer that question again from my side and then I answer yours. I've always wanted to come back to Nigeria, but the way to do it was always a problem. And before I came back, I had partnered with a lot of Nigerians trying to see how we can build these gigantic multiple $million hospitals. And then as all Nigerians, when it gets to the time for the show to start, everybody runs back. So a friend of mine, two friends told me, advised me. One was an older friend and one a younger friend. And he said, if you want to go back and start with what you know. Start small, what you know, and grow big. And what did I know? I knew neurosciences. I'm a brain doctor. So I went home and I started with something small, very small. That hospital you're seeing there started with a very small, like 10-bed, and then it has grown over 5 years. So another person who gave me an advice was Professor Fodile, who is a plastic surgeon in the United States. He had come back himself. He's an octogenarian. He's in his 70s now. He had come back to himself years ago, decades ago, and he couldn't succeed. And he said, listen, when you're ready to go home, cut the umbilical cord and go home. It's not easy to stay in this country, I'm telling you. It is not easy to reassimilate yourself here. But I think COVID did something for me because I was still going back and forth. and then COVID locked me down here, and then I learned to sleep. And I learned to sleep without an air conditioner. It was not easy at first. So whoever wants to come back, the opportunities are here. And I'll tell you, one of the things that that makes me feel good every day. Remember, I was chairman, right? But I was chairman, and you know what it is for a black man to be a chairman. And you know what it means. I'm being sincere here. But here in Nigeria, I've mentored a lot of people. I've helped a lot of people start programs. I've actually helped a lot of people go into residencies in the United States of America to do neurology and all sorts of residencies. But one thing that pleases me is that I wake up when I want to wake up in the morning, and I sleep when I want to sleep at night. Like last night, I didn't sleep last night because I was here in Lagos coordinating what was going on in Owerri, but I was happy doing that. And I didn't have to clock in and clock out, and I've worked myself. And there's a doctor who came here earlier on, Dr. Ngozi Onoha. She came in from the US. She came looking for me, and when she came, she said, "Thank you so much. You've saved so many people I've sent to you. Look at that." I mean, what can I ask for again at my age? Nothing more than that. So I encourage people to come back. I know what the problem is. Finance. Start small. Stop looking for that big money. Number 2, find a soft landing partner. We have helped a lot of people partner, and after some time they break away. Partner. Start small and then grow big. And when you understand the system and the market, you can break away if you want to, or continue to grow with us if you wanted to. Same opportunities are available at Eurocare, is available at Reddington, I believe so, is available at a lot of places. So there are places where you can go, and you also meet fellow diasporan doctors who can help you kind of assimilate and understand that. Stop pricing. Because he was saying that she bought peppered, what do you call it, snail, yeah, 4 years ago for 700 naira, and now it's 2,500 naira. I said, Ngozi, can we just keep quiet? Dollar is now $1 to 1,000 something. Something has happened in the economy. Spend the money and stop complaining.
Thank you so much. Please give a round of applause for them so far. We have a few minutes left. So let me start, Jim. Why are returnees and those interested in coming back to Nigeria only talking about Lagos and Abuja? We have over 35 states in Nigeria, plus 36 plus FCT.
But that's also not true.
It's a question. We're already getting hit on the panel.
Talk about storytelling.
No worry. Trust me. I live in a fantastic, big ranch, like 40 plus of land. You need to come there, you wouldn't want to go. And I drive like 5 minutes to work and 5 minutes back to my place. I'm very cautious of the security situations, so I don't go everywhere. But I also know there are some places in downtown New York you will not be able to go to at night. So why am I wandering around in the night? I go to my house and I have everything. Hey, tell my colleagues there that I have somebody who opens the gate for me. I have somebody who cooks for me. I have somebody who makes my bed. And I have all of these things. Can't get that in America. Can you? Absolutely no. And I'm employing 205 employees that I pay salaries that, you find out they use these salaries to support their parents, train their brothers in school. And it's amazing what this money does for people in the communities. You can't do that while you're in America.
Wow.
Okay, Nigeria Health Watch. This is storytelling we're talking about.
Vivian, this is your next storyline.
Yes, and then Dr. and him.
So, yeah. Mr. Jim, over to you.
Yes, please.
Please, why? I want to understand why. Why Lagos, Abuja? We have other states. We have Imo states.
Yes. First off, I think like the doctor said, it's a perception. It's not the real thing. But I think if you look at the proportion of those that are returning to Lagos and Abuja, you might say that it's higher. But then there are also other people who are returning to other places, just like he rightly said. I know of other establishments in places like Port Harcourt, in places like Jos, for instance, where I'm currently training, in Kaduna. There are lots of people that are returning back to those places. But I think largely, why the numbers are more concentrated in Lagos and Abuja is for obvious reasons. Security, these are like the best cities in Nigeria. It is believed that the kind of life that you have over there, you can easily get them in these two cities. But that is not really the reality, because we have seen a lot of them in other places as well. Like also Doctor said, I was in a webinar a couple of weeks back, and a doctor, I've forgotten her name, she has been in the UK for 35 years, and she came back to Nigeria. And then she was sharing her story with us, and she was like, while she was there, she has been a professor for a very long time, and she said she can't even afford to pay a cook in her house. But when she came back home, she was able to employ a lot of people. And the ripple effect of that is that you are not just returning back and taking care of your immediate family, you're also making a very significant contribution to the economy of where you are residing. So I think the land is green, and all we can say or we'll keep doing is to advocate that people should return back home, and let's together contribute to the growth and the development of the Nigerian health sector.
Thank you so much. Doctor, I would like you all to make your closing remarks, but I want to share some of the questions, but in your closing remarks, think through what you want to say about. People are asking about how the collaboration with the private sector can benefit the education and training of medical students in Nigeria. Another one says, even as a doctor in Nigeria, they're not able to even access things like mortgages. Somebody wrote the fact that while we're talking about the people jackpotting, what about those of us here who are here, but we're not really getting the real benefits of the system? Another one asked about how students can play a better role in fostering partnerships. So maybe in your closing remarks, I'll just ask that, please keep it to 1 minute, please. Just your thoughts around these areas, because there are people here that clearly want to know how, when, and why. So if you can just help them think through this, and keeping in mind that there are people here that are listening, and people also outside that are listening. Over.
Okay, maybe I should go first.
Yes.
So first off, earlier on we were saying that we're talking with ourselves, the private sector, the government, none of them are here. I think we can do something about that. If they are not here, we can take the message to them. By the time they see that the private sector is resilient and is not backing down, I think the government will not have any choice than to want to key in into the train. Because there's no gainsay about the fact that, yes, for the system to move, we really, really need the public sector. We need the government to come in place in terms of policy, in terms of the law, in terms of regulations. It is very important they get the message, and they get the message rightly. Having said that, medical education and training. There are a couple of states in the northern Nigeria that they go into some sort of bonding for medical students. Some start as early as you are 200 level. Some, once you cross over to the clinical, they place you on some sort of bonding scheme where you are paid monthly, and your materials and books that you need for your training are provided for you. When you're done, you are expected to return back to that state and serve the state for a period of time. This we have seen to be very effective over the years, because a lot of these persons, some of them will have to contribute back for like 5 years, some 7 years. So that period of time, you see that for you to want to just stay, serve as just a medical officer to the state government, you would want to take up some sort of training here. So that in itself has contributed to keeping people back here and discouraging them from leaving the country. So we think the private sector also can do something in that regard. It might not necessarily be the same thing, but they can provide some sort of soft loans or grants for the medical student. And you can agree that in the society, the medical student, a lot of us actually, we've been over the years shown to be people of high integrity. So you cannot go into some sort of agreement with any medical student by way of training that person, even if it's for 2-3 years, and that person will not want to come back and make contributions to you or to your establishment or to the state which he or she trains. So I think these are some of the things that we can do to encourage our students to stay back. And lastly, we can also send some for training and retraining. Just like a lot of people have gone back, gone out, get some of these kids, because we understand that yes, the system is not there yet. There's a lot that still needs to be done. We can send some out for training. If it's for a period of time, go get these skills. Once you're done with your training, then you return back home and then make your contribution to the system. Thank you.
Thank you very much. Please give him a warm round of applause. Dr. Njide, over to you. Closing remarks.
Okay, so my closing remarks really are that referring to medical students now, instead of japaring, to think of the inconvenience you feel when you try to access the system. Oftentimes, the best ideas are created out of a non-existent system. So it's really around thinking out of the box, finding solutions instead of waiting for someone else to find it for you, finding a mentor. There are some of us who actually mentor medical students. I have a lot that I communicate with. So I think it's also important that the youth have a seat at the table. Unfortunately, the youth or the young people are growing up in a digital world, but yet the policies are being made by analog policymakers who don't even understand the digital world. So the onus is on the students to organize themselves so that they have a voice and a seat at the table. But some of us can facilitate, some of us can mentor. Also, to quickly mention that today, actually, for those who are interested, is the launch of the Digital Transformation of Health Lab. It is the follow-on from the Lancet Commission on AI, artificial intelligence for the youth and developing countries, where we are going to be testing innovations and also looking at governance around data, health data, so that we can move towards a world where we can use data for data solidarity as opposed to mining it for profit. I think the time has come now where you own your data, you determine who uses it. So again, these are some of the initiatives that are coming out. But for African Nigerian students, I think that you have the power to actually think out of the box. And I think the opportunity is now.
Thank you. Thank you so much. Professor Chilochi, your closing remarks.
Thank you. So I think that we need to mine all of what has been said today. We've talked, for example, about the importance of data, telemedicine, even the way we approach bonding. So that was an interesting one for me. And develop a solid policy environment. There is no way we can do this without government, because we know what the system is like. The private sector, there's a significant part of care that is delivered by the government, by the public, and there's a significant part of the environment that is provided by government, and that is why some people are reluctant. So we need to engage. I think the private sector needs to engage the policy process to ensure that we have what we need. Even in terms of telemedicine, there's so many gaps in terms of regulation. So what that often means is that even getting funding can be difficult. So when you put all of this together, we need to have a holistic policy environment, and I think that the private sector should be front and center in that process. I will also come back to what I've said about storytelling. Just listening to Dr. Anyanwu, I think, makes my point. Even people outside of here, you can imagine when you live outside of Nigeria, the only things you hear, like people say to me, you can't be a citizen of another country and be there. What are you doing there? Because they don't know what is going on here, right? And I think, as simple as that may sound, that it is a very important part of what needs to happen. And I'm sure that Nigeria Health Watch can lead that. Healthcare Federation of Nigeria can lead that. People like Dr. Shitabe, who is sitting down there, just like Dr. Anyanwu, they have a lot of stories. Some of them have come in from time to time before they came back fully. All the stories need to be out there. Thank you.
Amazing, amazing. And Dr. Anyanwu, closing remarks.
Thank you. Well, I have two messages for two groups of people. One, the doctors who are here already, and the diaspora doctors. So let me start with the ones who are here already. You know, the truth is that unfortunately, because of the way government looks at healthcare, it's a social service, and therefore it's very underfunded, and the people who work in healthcare have to be underpaid. You shouldn't look at healthcare that way. Healthcare is a good business, and there's money in good healthcare, but you need to, first of all, get training and provide quality healthcare. There are a lot of people in the system looking for quality, good health care. And therefore, those of you who are here, who run abroad, keep in mind that a lot of them who run abroad don't actually always succeed. There are a lot of them that go from brain drain to brain waste. I mean, I can tell you a lot of people I know who have jabbed for the past 6 months and are still doing nanny job and home care and can't even get into the system. And even the so-called UK system, they take them there. You see a nephrology or whatever orthopedics consultant going to work as a GP or senior house officer. We know these things happen. Retrain yourself. As people are running away, opportunities are here that you can retrain yourself in several things. I mean, there's a guy who's at FCC, a young cardiologist, who now can do intervention. There's one working with Dr. Hamid Naniwo, who's an interventionist that came back from America, learning how to do these things. These people are going to occupy these spaces. And then for those who are abroad, trust me, it's better you come back when the ovation is loudest. There's a lot you benefit from being here. Well, number one, you mentor other people. You're not going to live forever. Number two, you save a lot of lives. I can't even begin to talk about how many lives that would have wasted that we have saved. My father died in a very unfortunate circumstance 19 years ago. He couldn't get good care. Now, at least most people who come to me will at least get, we're not always successful, but they will get some sort of good care. You know, and again, their families are going to help by even employing them. And I tell you one thing, I know one of the things that holds back our guys abroad, it is Newton's law. Every object continues in its state of rest or uniform motion unless impressed forces act on it. I went through it. It was so difficult for me to turn in that resignation, and one of my friends kept pushing me to turn it in, and the day I clicked that email, it was like the Holy Spirit descended on me. And then, and then the rumors started. He's not going back to Nigeria. He's going to Minnesota and all sorts of things. Trust me, today I post something in the social media and LinkedIn. 70% of the people who will view it will be people who, from that hospital where I worked in. A friend of mine who went there to work, there was an article about me, and I talked about having been the chairman in Novant. You know, they have a way of picking up these online articles that, you know, relate to their hospital. And they printed it, and they were spreading everywhere. Dr. Anya will look at the amazing thing he's doing in Nigeria. I mean, where do I start? Where do I stop? It's a decision that you have to make. I recognize it's a hard decision, but we've all talked about ways to make that decision, and nothing can be so rewarding that I'm trying to drag my wife back to Nigeria, and I hope she comes back to Nigeria soon. Thank you.
Thank you so much, Dr. Yawo. And my parting shot to everyone is the fact that, one, there's no place like home. Number two, like my late mother would say, whatever you do in life, always think of home. Some of us have gone over there, we're back in Nigeria, and we're doing the things that we're doing now because we know that we can do it. So about it is that take what you have, you know, when you go over to these places, mark your time. Mark your time. And like you rightfully said, when the ovation is loudest, come back home. You know, like the Bible says, fear not. You have to come back and take the bull by the horn because this is your country. This is your country. I know it's not always easy, but always remember that this is your country. When you go over there, they will show you that that is not your country. Thank you very much. So, please, let's rise for our guests. If you enjoyed the panel, please give them one round of applause.
Picture.
Oh, okay. Yes.
Thank you so much, Ekenem, and our amazing lineup of panelists. To set the tone for the next and final panel session, we'll play a video from Dr. Amit Thakkar. He is the executive chairman of Africa Health Business. And I'm really excited. Why did cue up the video? I'm really excited that, the emphasis on storytelling and sharing these stories. Interestingly, for us at Nigeria Health Watch, it's a strategy that we also deploy because we realize that, yes, we push for these issues, but we know that people are also addressing them. So on our website, you have our Touchlight series where, just like the name implies, we put a touchlight and spotlight these interventions. Interestingly, we've actually gone to Owerri, all the way to Owerri, to report a story about the work that Dr. Benjamin Anyanwu and his colleagues are doing there. On our own, nobody sponsored us. We sponsored ourselves to go tell that story. We've also told the story about Reddington. So you can find these stories on the Nigeria Health Watch website, and similar stories of initiatives that are addressing health issues in Nigeria, because it's not just about the problem, people are also addressing them. So we listen to the video from Dr. Thakkar to set the tone, and we get into the last panel session. Thanks.
My name is Dr. Amit Thakkar. I'm based in Nairobi, Kenya. I am the executive chairman at Africa Health Business. I'm also the president at Africa Healthcare Federation. COHA, which is the Coalition for Women's Health in Africa, was launched in 2022. They clearly defined 3 active pillars to deal with in improving women's health. Pillar number 1 was on cancer and oncology management. The pillar number 2 was on sexual and reproductive health. And pillar number 3 was maternal and newborn health. And 3 targeted countries were selected: Ghana, South Africa, and Kenya. We realized that through the collaboration of public and private sector, women's health systems are much stronger in areas where there is better access to health services, starting from antenatal care to diagnostic care to even digital health services and post-delivery services. Effective supply chain enables women receive their treatment in time, which are of full quality, providing them the services that they need. I think public-private partnership in Nigeria is a great foundation on which to rest women's health, to make affordability, accessibility, and quality improve. Especially in the last 10 years, we've seen a very high level of integrated approach to women's health by both public and private sector. Let me start with the regulation. The regulation allows both public and private sector to equally provide healthcare to women across the country under the framework of receiving family planning supplies through donor funding. The ministry found it very useful to enable private sector receive family planning supplies at no cost, and in return, we are offering the same to mothers at no cost. One other great example is the immunization and vaccinations. Through Gavi, the public sector receives vaccines that are essential under the KEPI regime, Kenya Expanded Program of Immunization. These vaccines are now also available in the private sector, and many children have received vaccines from private sector facilities, again at no cost. So I think Nigeria can learn lessons from its neighboring countries, from Kenya. It can pick some of the ideas that can be replicated. Nigeria is also very forward-looking and positive about the integrated approach between public and private. The dual system in Nigeria exists. The dual system in Nigeria works. What I think we need to fix in Nigeria is the health financing and the funding system, bringing in a national health insurance cover that is effective and enabling more women to have access. In Kenya, technology has played a really amazing role in making payments and settling bills for health providers, especially when it comes to maternal health. Another area where technology really works well is around telemedicine, where women at distant places can access care from a professional without traveling these wide geographical areas. That will reduce cost and bring quality care to the women. The third area is technology tools, such as the ultrasound or the portable ultrasound. Before, the ultrasound machines were huge and they were very difficult to move around, and you had to visit the health facility. Now, with the portable ultrasound, which are handheld, you can have a community health worker doing an ultrasound for a woman who is expectant and be able to pick any at-risk pregnancies. Those images are then sent to the professional who analyzes them, and those at-risk pregnancies are given an alert to visit the healthcare facility as soon as possible, therefore reducing complications and reducing maternal deaths and infant mortality deaths in the community. So the Nigerian stakeholders have already started the process of getting organized. I have seen that the Healthcare Federation of Nigeria, which brings the private sector together, are strong. I have also seen that within the stakeholder group, there is a specific group that focuses on digital health. I would like to urge the digital health partners in Nigeria to strongly form a working group on improving maternal health. This will enable innovations and applications be propagated and their use expanded across the entire country. So through an organized system, we should see a widespread application of technology to improve women's health in Nigeria.
All right, thank you, everybody. Good afternoon again. You've been wonderful audience. Thank you for being here. If you're still here, we have one more panel session to go. But do we still have your attention? Do I still have your attention? All right, just to warm you up a bit so that you're more engaging, I want us to do a clap. Are you ready for me? By now, you know I have something to do with numbers. It's only because I like money. So you're going to clap. I'll call the number and you give me that number of claps. Let's do 1. Everybody, let's do 1. We're going 3. We're doing 5, 7, 2, 4. Thank you very much. We're going on to the next panel session. As you heard in that short video, it's focusing on maternal health, and we'll be looking at leveraging the private sector for quality maternal health. I really look forward to this session because I'm a women's rights advocate. So let's listen to the next session. To take us on this session, please help me welcome the executive chairman, we just listened to that. Please welcome Dr. Amaka Moma Haruna. She is of the Girl and Women Empowerment organization. She's also the senior specialist at the World Bank Group Health, Nutrition and Population Global Practice. Please put your hands together for Dr. Amaka Moma Haruna.
All right, thank you everyone and good afternoon. And I've said we should play some music because I hope nobody will doze off well on our panel. With the permission of the House, and I've said we should do some music, but well. So welcome to the last session of the day. Promises to be the most interesting, I promise you. Because maternal health, maternal mortality is very important. It's, I don't want to be biased, but maybe it's the most important session of the day because it really is the bedrock of our healthcare system and a core indicator of whether or not a country is doing well. I am a Girls and Women Empowerment Specialist. I'm doing a program with the World Bank. There are about 12 of us in Africa, and our work is to strengthen a lot around girls and women empowerment issues cross-sectorally with a very core focus on the healthcare system because that translates into every other system in Africa. The beautiful thing about maternal health is that every issue we have with it is preventable. Every issue we have with it is preventable. So who knows the Nigeria's maternal mortality rates? Since we're all trying to wake up, hello? Any guessers, any wild numbers in the house? Per 100,000. How many do you think? 500? Nope. Any other numbers in the house? 580. Oh, thank you. We're a little bit, no, we are big, so we are larger than that for the good and the bad stuff. Any other numbers out there? Anybody want to throw out any other numbers? Okay, so Nigeria has 1,047 per 100,000 live births. Between 2000 and 2020, there's an 8% improvement in our maternal mortality rates, and that's not a lot for a country with this size. So this is a bit of a big issue. And this afternoon, we're going to be listening from people who deal within this area, but from another angle, not from the, oh my God, women are dying, but really to see how can private sector come in to help us solve the problem. Research shows that households that have a maternal death, spend at least a third of their income either in trying to prevent the death or the aftermath of the effects. A lot of that can be prevented when you have private healthcare. The private world coming in to, support public healthcare systems. So we'll get right into it because I've been told I have fewer minutes. That's the problem with being the last of the day. You are squeezed with time, but we promise you it's going to be very interesting. So before you leave, you have something on your mind. We're going to kick off with our first panelist today. Do we have is there a sequence? Okay. Iyadunni Olubode, please, you're welcome. She's Director of Nigeria Programs, MSD for Mothers. You're welcome. I'd have liked to have some music playing as she comes, or maybe she can give us a dance. So thank you to wake everybody up. You're welcome, Ms. Olubode. Next, we have Dr. Tokunbo Oshitabe. He is the CEO of Duchess International Hospital. Thank you, Doc. You're welcome. No dancing? Are you going to give us a dance? No dancing. Do you have 2 left legs or 2 right legs? You're welcome. Next, we have Dr. Nneka Mobison, who is the CEO of MDoc. You're welcome. You're welcome. Are we getting a dance from you? Oh, thank you. And last but not least, Dr. Chito Wana, who is the CMD, Tabitha Medical Center. So, for your information, Dr. Chito took care of my first pregnancy. So, it's a personal full circle moment. So, she's overqualified because the baby is fine. So, she's very qualified to be on this panel. So, we're going to get started. It's going to be an interesting discussion, exchange of information. If you're online, please go ahead and tweet about everything that is going on here. Also, make sure you send in your questions once the panelists start talking. So we'll get right to it. Thank you, everyone. Should I call who's first up? Okay. Okay. So to start us off, I'm going to be totally biased and start with Dr. Chito. So please, you have the floor.
Good afternoon, distinguished guests. And being on the last panel is one of the advantages that most things have already been said. Then the disadvantage that some of you may be already sleeping. So I'm going to try and make this short and sweet and come from a kind of a different perspective. As you know, I'm an obstetrician, like she said. I'm also an owner of a hospital that has an MOU with the private health sector to deliver care in one of the facilities in FCT. And I'm also an executive member of the National Guild of Medical Directors, which comprises of all of private health facility owners. So that perspective I'm going to come from is from the perspective of the private health sector providers. A lot of times I go into meetings and they're talking about engaging the private sector. And I remember this meeting I went into and I sat down there and think, okay, they're going to talk about us too. And they went in and they talked about very important things, engaging private sector, the banks, corporations, foundations. And at the end, I didn't hear providers. So let me go back to a recent World Health report that listed Nigeria as the second on the list of countries with the highest maternal deaths, and that was recent. As an OB, the one thing I do know, and someone mentioned before, is that we understand the risks that can lead to maternal mortality and morbidity, and we know how to manage patients and prevent poor outcomes. So that makes me believe that one of the main reasons why we still have high maternal deaths is because of lack of access to skilled providers. If you take a moment now to reflect on the state of our hospital or our health sector right now, you see that a lot of health facilities are grappling with the shortage of resources, of poor infrastructure, and of course the shortage of human resources. This is a time when private health sector providers cannot be ignored. The governments and most governments in Africa are very comfortable in engaging with not-for-profit private health providers like faith-based organizations, but there's still a huge gap in engagement of private health sector for-profit providers, and that's my focus today. Now, I remember I think CEO of Private Health Sector Alliance mentioned that, it's like a marriage. When it comes to us, I think we haven't started courting yet. So I'm gonna go, I'm gonna move slides of time. Can we go to the next slide, please? Or do I have that control? Okay. This talks about engagement, which we all have heard about today, so I'm not gonna waste time on that. What I'm going to face right now is why haven't we started courting? Why does the gap exist till now? Why do we keep talking about it, but yet have you asked the question, is the government really willing to engage with us, or are we really willing to engage with them? Sometimes a picture tells 1,000 words. I guess you don't need to guess. The big man is the government with the megaphone, and the small man is us, the private health sector providers. This tells you where we are right now and why there is this huge gap. So one of our challenges, I'm going to list some of those challenges. One, lack of trust. There's a huge lack of trust between the government and the private health sector providers due to past experiences. Another one, a lack of framework. This is what I struggle with. So for us, and my MOU with the government or the primary health sector health board was really kind of, I would say, self-initiated. We didn't go through Farm Access or any big foundation. There was this talk before time about how can we, as a member of the Guild of Medical Directors, how do we engage with government? What are the things that we can do to help to bring access to care to these women that are vulnerable? So I decided to give myself up like a guinea pig and see that if I engage with the FCT and actually do take on a PHC and deliver care there, that maybe it will work. One of my major challenges is the lack of a policy framework guiding an effective engagement. So that has been one of the struggles we've had, and actually it's quite discouraging and really, I think, risks the sustainability of the relationship. So this is something that's a challenge. Financial strain. We all know about inadequate financing of the private health sector. A lot of times that could be also because most of us owners of hospitals are doctors and have sometimes a very weak knowledge of how to run it as a business, and we struggle with that. So most of these funding and loans that we talk about, we hardly ever qualify. Let's say 10% of people actually have access to these loans. When you think of the private health sector sometimes, think of all these big hospitals, the innovative hospitals, but the most common hospitals are actually small and medium-sized hospitals, and they're the ones that actually completely lack funding or the ability to get financing. So that's a struggle as well. And of course, coupled with NHIA, who is seen as a vessel to providing or to engaging the private sector in providing care to the population. Because of their significantly poor tariff and the hesitancy to dialogue with private health sector providers, you have many hospitals not willing to participate and definitely not willing to offer secondary care to the population. And that's caused a significant gap that we need to look more into. Regulatory barriers. I believe strongly that without proper regulation, we cannot have a quality healthcare system. But for private providers, we also understand that we are taken care of by the national, the state, and the local government. And sometimes inconsistent regulations can impede private sector's ability to operate effectively. Resource imbalance. A lot of times when it comes to capacity building or human resource, we find out that it's more focused on the public sector. There's one Ministry of Health, two health systems, and it's very important for them to remember that if you do not build the private health sector, you cannot engage with them, as I know. One of the times we went to Anambra to do our work, we went to this small village, and in that village we thought, okay, we're there for 1 week to offer surgery and also maternal care. We'll use the primary health center. When we went there, it was closed up and bush was everywhere. So the only place we could use was a little hospital, a small private hospital in that village. That was the primary source of healthcare for the people in that village. So when you keep your capacity building, resources, and operational guidelines only to the public sector, then what happens is that you miss out on essential people that are offering these services in these communities, and these women and these mothers will suffer. Now I'm going to take a look at the government challenges. Regulation, I talked about that before. I'm not going to say much about that, but we know that regulation is the responsibility of the government. And right now, one of the things that I think impedes them is capacity. And so it's very important to separate the wheat from the chaff, to be able to actually know the private health sector to engage with. Remember that when we talk about private health sector facilities, there are some manned by providers down to some manned by community extension workers. It's very important to regulate those two sectors to make sure that we're all practicing within the scope of our training and again, according to regulation or standard care. Information sharing is very important because most times the data you see is from the public sector. There are great challenges the government has in getting data from the private sector. There was a survey done once wondering why doesn't the private sector give data to the government? And you know what the answer was? We don't trust them. We do not trust how they will use the data because of past experiences. But yet we know that you cannot solve a problem without data. And if most times development partners focus only on the data of the public, they're not getting it right because they have lost a huge chunk of the data in terms of the private sector. Most facilities, yes, are in the public sector, but the private sector delivers at least over 50% of care in Nigeria. So what they do is very essential in improving the health sector as well. Political will. Honestly, sometimes I wonder if the government is willing to engage with us. There's a lot of tussle, a lot of talk about this, but we don't see the courting happening. We don't see the relationship, the dialogue. We're not called to the table at all in terms of policies or processes, nothing like that. And that actually affects us in the private health sector. And sometimes some leaders are interested, and the next time some leaders are not that interested. The lack of consistency in the interest to engage with the private health sector creates a gap as well. Public perception. Everybody likes to believe that the private health sector puts profit above patient care. I want to change that story. Like, talk about storytelling, I want to change that narrative. Healthcare is a business. I work in the US, I work in Nigeria, and it's a business in all those places. It's what it is. To give healthcare is expensive, and that's why we're here talking about private sector investment. So it's not true that we do that, but we have to make sure our doors are open and we sustain practice and we innovate and we grow. So that's essential. So I want to change that. This perception has caused a lot of gaps in our health sector in dealing and engaging with us. And I think that perception needs to change as well. What are some few solutions before I sit down? One is we need to create policy framework that allows effective engagement between the government and us. That should be clear and should be implemented. Regulatory reforms. This is time for technology. I know Lagos has done that in their regulation system where they've onboarded hospitals on a portal. Abuja just launched theirs. I think the government should take time to invest in technology in all states, because when you do that, you're able to actually be able to engage with the hospitals that have the standard basic facilities and ability to provide care. And this allows for effective and actually effective engagement. Financial support. When we say this in some meetings, government thinks, oh my God, they want us to give them money. No, that's not what we mean. But in every engagement, there should be incentives. There should be incentives to allow that engagement to be sustained. Without those kind of incentives, it's not going to be sustainable. And when I talk about incentives, I talk about things like loans at low interest rates. A lot of times when we talk about loans, the government is giving is like 27%, 30%. And people will shy away from that because it's a really high interest rate. Guarantees, tax waivers, subsidy on equipment. I don't know if you guys know this, but most of our supplies and equipment are imported. And because they're imported, as the economy declines, as the dollar rates go high, we barely can afford to buy these things and not change our prices. So for us to deliver affordable care, the government must support the private sector so that we are able to do so without causing our hospitals to shut down. And also, we should talk about NHIA, but the government is not here right now, so I'm not going to deal with that now. They're about to launch their guidelines, but it's very important that they dialogue about their tariff system. It is either going to take hospitals out of the NHIA on secondary care, or it's going to force people to deliver substandard care, and we cannot afford that if we're talking about improving quality care. Now, I'm just going to conclude with this. This is where I think we need to get to. From the big man with the megaphone, talking and yelling all their guidelines and process for us to digest, we need to get to where we are shaking hands. Sorry, I forgot to talk about this. Let me just add this briefly. Transparency and accountability. There's no room for corruption in the health sector. And that's something that I didn't hear anybody talk about today, but it's something that's literally crippling engagement. You engage and you feel there's something that's not right, it's hard to make impact, it's hard to actually engage effectively. So there should be an anti-corruption framework put in place for us to be able to engage the private sector and let them trust the process. So in conclusion, government-private health sector collaboration is important for Nigeria's healthcare future. We must prioritize policy, information exchange, regulation, financing, and public service in harmony with the private sector. Our goal is a comprehensive healthcare system ensuring quality care and financial security for all Nigerians. Let's unite for a healthier, fairer Nigeria as we strive for improving maternal health outcome or universal health coverage. I want to leave you with these words of Martin Luther King. Injustice in health is the most shocking and inhumane inequality. Thank you for your attention.
Thank you, Dr. Chito. That was awesome. Thank you very, very, Riley. I don't know when our next elections, I have to put you up for a candidate because that's equal to a politically motivated statement. With that, people will want to go. So thank you. I did not know she had that activist side because it really is, you have to be that way to get things moving. You have to be nobody cares, but I care kind of person. So thank you for that. Very Riley, very motivating. And you kind of set the tone. I know you said a lot around technology. So we'll just jump over to Dr. Mobisin. Thank you very much.
Hello, everybody. Hey, I guess I'm challenged with height. I just want to make sure everybody's awake. Okay, good. All right, so it's a real pleasure to be with everybody here today and talking about this topic, about women. You know, I think you've heard some of these aspects today, but the reality is that women, mothers, reinvest 90% of their incomes back into their families and their communities. And that compares to men who reinvest. Can we have a guess as to what percentage men reinvest back into their families or their communities? Hey! 101. Okay. If you want to say 90%, please raise your hand. What did you say? Ha! Can we have some women answers? You are hearing some men say 100 and 101%. Anything else? 60. Okay. All right, so I'm hearing 60% and above. So 90% we said for women. The data actually shows it's 30 to 40% for men. So let's be asking you, where are you putting that other money? But we'll leave that one alone. The point is, the data shows that women invest in their families and in their communities and in their societies and in their countries and therefore the world. Okay? So investing in maternal health is an economic benefit that has ripple effects on all of us across the world. And therefore, it saddens me that we actually have to be here today to talk about why partnerships and public-private partnerships matter for women when the evidence and the data is there. It also bothers, I'm just coming from Dakar, the Grand Challenges Conference in Dakar. And I made a statement to somebody that I've noticed that whenever I'm with like really brilliant people, doesn't matter what conference it is around the world, that sometimes when we dangerous, quite frankly, because it almost feels like an affront to your brilliance and to your intelligence when we're saying, hey, are you focused enough on women? Are you focused enough on maternal health? Are you focused enough? And so just want to kind of encourage everyone around, just like reflect on maybe some of your biases, reflect on what are you doing personally to invest in women. And that's how I'm just going to invest in women, invest in maternal health. Because you ultimately, and your children and everybody else will ultimately benefit if you invest in women around the world. So let me start with, I thought I would actually talk about MDoc today, and that's the company that I have co-founded and I run. I co-founded MDoc with my husband, Imo Etsuk. And I think it's important to talk about MDoc because it exemplifies partnership. It exemplifies private partnerships, it exemplifies private-public partnerships. And it's been a joy, and it's also been very, very, very difficult.
Recording in progress.
Okay. So a little bit about me. I am a mechanical engineer turned pediatrician, turned consultant, went into NGO world, and then I got angry. In fact, I saw some of my former colleagues and friends from the quality space, which I was very active in years ago. But working in the development space, I actually got very, very, very angry because I felt like as a country, as a continent, we were not doing enough to invest in people as a whole. And we weren't doing enough to leverage the power of digital that we were seeing around the continent. We were seeing mobile penetration rates just going through the roof, and yet we weren't doing enough to leverage that. And so, my father died prematurely from chronic disease, and many times we would say Nigeria is what killed him. And I was like, we cannot continue to have people die when we have innovation and we have so many opportunities to grab a hold of. And that's what we do at MDoc today. So we provide virtual self-care health coaching to people living with or at risk for chronic health needs, as well as regular health needs. Specifically, you've heard about the problem, so I don't want to highlight it. We all know. But the reality is, at MDoc, we decided to focus on chronic disease because of the reality is it intersects with maternal health and neonatal health. It intersects actually with everything in the sense that when you focus on prevention and you focus on self-care and you focus on helping people develop the confidence and the agency that they need to live healthier lives, that translates into everything, every single thing that they do. And so we believed that we could really try to galvanize a movement around helping people focus on themselves and the 99% of the time that they're out of the healthcare facility. We, I think through partnership, have learned that we've had to have a 4-pillar approach. When we started, we really thought we were just going to have a web and app-based platform and support people to track their metrics, to receive nudges, and drive them to adopt behavior change. But then we soon realized, we started out actually working in the community, and we surveyed 1,000 people across, I guess, southwest Nigeria. And we heard from them what their pain points were. And we recognized as we started to build that a digital alone approach would not work. And so we created this 4-pillar approach. And very briefly, the first and the real core element is our comprehensive digital platform called Complete Health, which allows us to provide virtual coaching through a human health coach, as well as through a broader self-care team that support people to actually make the specific lifestyle modifications. So whether it's exercise, nutrition, medication adherence, people get their own coach who support them in that journey. We have now integrated, over 2 years ago, post-COVID, a lot of us have spoken about COVID, we decided to integrate AI. And so we developed a chatbot called CAM, short for Nkem, also short for Kemi, to really be that supportive, actually initially just to answer questions on frequently answered questions on hypertension, and now we're investing a lot around building its ability to be a coach. The second piece is Navi Health, which is our health directory for healthcare facilities. So MDoc does not prescribe, we do not diagnose. We, as I said, here for people the 99% of the time that they're out of a healthcare facility. So we created Navi Health because we realized we needed to be able to guide people on where to go for in-person care when they needed it. And partnership has been a critical element of Navi Health's growth. People are able to review their experience at healthcare facilities. And we've specifically designed this aligned with the quality domains so that they can actually give those reviews so that healthcare facilities, whether they are public or they are private, actually know alongside those domains where they can make investments and what they need to do. We've done a lot of this work with support from MSD for Mothers. The country director for Iyaduni from MSD for Mothers is here today, Iyaduni Olubode. And without the funding support and having people believe in us and be willing to take a risk in us, we would not be here today. So let me just highlight that. That's the first element of partnership. Being able to identify organizations, entities, actors, even from the government, who are willing to take a risk and actually have the trust in you to be able to collaborate, co-design, and invest together. The third piece of what we do are nudge hubs. These nudge hubs are essentially health kiosks that we set up in the market, outside healthcare facilities, in the community. And this is because we recognized we needed an in-person approach to help build people's digital literacy, because mobile phone penetration rates are not appropriate proxies for literacy from the digital perspective. Also, that's where partnership came into place. We reached out to people just saying, when we wanted to test, because everything we do at MDoc, we test, leveraging the principles of quality improvement, we test before we implement fully. And so we reached out to a number of healthcare providers and said, public and private, and said, hello, please, is anyone willing to kind of collaborate with us on this idea? We're thinking of a physical brick and mortar presence where we can actually have a small health kiosk equivalent. And we reached out to like 20 healthcare providers. 15 said, come yesterday and come and set up and test together with us free of charge. That's partnership. That's collaboration. They were willing to work with us and learn together and experiment together. And we actually did a pilot at General Hospital Ikorodu. We tested this out, and we actually were able to demonstrate improvements in blood pressure outcomes and blood glucose outcomes in people with hypertension and diabetes. Partnership worked. The final piece of what we do is teleeducation. So the first three elements of our approach are all, again, patient-facing. We don't call them patients because they're not our patients. We call them members. But the fourth piece is the provider. We recognized that we wanted to work hand in hand with healthcare providers around the patient. And so we partnered with the University of New Mexico's Project ECHO. University of New Mexico came out with this methodology over 10 years ago around really leveraging this principle of adult-based learning, real cases, real patient cases to train. And so we started holding teleeducation programs and some in-person quality improvement programs to train healthcare providers. And today, we've trained over 15,000 healthcare providers across Nigeria, across Africa. And it's, again, through partnership with governments, we've partnered with the Lagos State, we've partnered with the broader ministries, we've partnered with other social enterprises across Africa to also create TECLA, which is the teleeducation to equip clinicians and leaders across Africa. So I'm just underscoring that this notion of how partnership can actually improve health. Now, how does it relate to, seems like it's gone off. How does it relate to maternal health? Well, with MDOC today, we serve over 110,000 members. Over 80% of them are women, and majority of them are low income. A high percentage of, and almost all of them are women of reproductive age. As a result of the funding support that we've had from MSD for Mothers, and in partnership with organizations that are actually here today, I think HSDF, some of you may have seen Project Aisha, Ingress Health Partners, IHI. We've partnered with and are grateful forever to Nigeria Health Watch that has helped really elevate these stories of the women that we serve. We've been able to leverage this 4-pillar approach to provide that coaching support to women, so that we are there around, our coaches are there around the clock for these women. When COVID hit, we went from supporting women, answering questions like, oh, what exercise can I do to reduce my blood pressure, to, I am so afraid. My baby has a fever. I can't go to the facility. I'm scared. What can I do? Please help me. Or, I'm 38 weeks pregnant. I'm bleeding. I'm at the hospital gate. The gate is locked. Where do I go? Now, MDOC's focus is self-care. Again, we don't replace the provider. But if our answer in that moment is call your doctor, what will happen? We're not talking about high-income women here. We had to be able to be there to support them. And quite frankly, I couldn't sleep at night because I was worried about the burgeoning responsibility around having to support people beyond the breadth and depth of our experience. That's when I leveraged the fact that we harness technology at MDOC to leverage artificial intelligence. Artificial intelligence allows you to be able to call so much data to provide a much more personalized conversational experience with the members that we serve. And again, that was through funding support from MSD and a whole host of other partners, including the UK FCDO, to really enable us to do that. Now, we partnered with healthcare facilities as well because they recognized that we could support them in reducing the burden that they had. Again, public sector and private sector. We've been able to create different learning networks of public and private health sectors to focus on shared aims of maternal mortality reduction. We leverage quality improvements. HSDF that's here today has been able to teach and build their capacity in quality improvement, training them, and then with that, they're focusing on that supply side approach, and MDOC focuses on the demand side, really the women, supporting them outside of the healthcare facility. But we have that hand-to-hand support, working together with healthcare providers around the women. And that's translated into improved outcomes in terms of their blood pressure, their blood glucose, reduction in preeclampsia and eclampsia. We've seen improvements in their PHQ scores, which means an improvement in their mental health. And we've seen an overall improvement also in their self-efficacy. That's their confidence in being able to actually live healthier lives, their ability to do what they need to do to live healthier lives. So I guess the critical point I'm trying to underscore here is that partnerships can happen. They're very difficult a lot of times, but they can happen if you start small, if you test, if you actually agree and come together with a shared aim and you highlight what that aim is and you commit to it. You develop metrics to hold yourselves accountable and you work closely to do that. Some of the challenges that we've had have been around, number one, just the notion of digital. MDOC started in 2016, and everybody told me I was crazy for leaving what people thought was a great job to co-found MDOC when nobody believed that digital could work for health in Africa. Until today, people still don't believe it. In fact, it's now a recruitment requirement at our company that we have people who understand that, who believe that technology really, really matters. I think this thing is really not working. Okay, so So, and I'll close shortly. I just want to highlight, and the second, sorry, one last piece too was around digital literacy. MDOC, we have had serious, I guess, coach burnout because our coaches have had to really invest in building that literacy so that women really know how to use their phone for healthcare. Know how to actually, okay, what does it mean when my BP is going down? Okay, the graph looks like this. Or even as basic as what is an OTP. We've had to teach people how to make email addresses, and now through additional funding from MSD for Mothers, we're going to be expanding beyond just physical health. Because we recognize that if we support women to invest in financial literacy, us teaching that OTP can go further along. So they can use that OTP and their understanding of how to use an OTP and more to set up a bank account. To actually maybe apply for a loan that's not predatory to set up a small business for themselves and their families. So again, that we have that ripple effect across the community. And so in closing, I would say that partnerships are possible. They're possible if you start from a place of understanding that rising tides lift all ships. If we work together and we work with trust and we say, let's start small, and we hold ourselves accountable, and we're willing to be direct with each other and not feel competitive. And I just want to say that again, work together and not feel competitive, because doing this work has actually been a bit surprising to me. We're working in a space where women are dying by the minute. Women are dying by the minute, but sometimes there are some challenges around collaboration. People will feel that, we want to make sure our name is there, our company's name is there.
Dr. Mobison, I've been mobilized to mobilize you.
Okay, I'll stop. All right, you can mobilize me. So I will end with this. Partnership is possible. Partnership is possible, but you've got to commit to it. And also, you've got to commit in this day and age to technology. We cannot afford to stand on the sidelines. We've heard our first panelists talk about technology. We've heard the other folks talk about technology. It took COVID for us to believe in technology. Dr. Ndili highlighted why we need to focus on technology. I want to underscore to everyone, let us partner as we look to the future. If we really want to focus on maternal health and uplifting women, let's leverage AI. Let's work together to not be spectators, but actually be active contributors, ensuring that their voices are heard and that we're working together. Our voices, our local languages are heard in this artificial intelligence journey that's moving forward. Small plug, MDOC has partnered with the Science Foundation for Africa, another partnership, to hold Nigeria's artificial intelligence convening, where we're going to talk about AI and policy and regulation on October 27th. So please hold that as your date, where we'll also talk about and actively leverage partnerships to talk about how we can improve leveraging AI to improve elements such as maternal health so that more women can live and more communities can benefit and our society as a whole is transformed in the most positive way possible. Thank you.
Thank you, Dr. Mobison. Sorry for being mobilized, but I guess we don't have the whole all day. I'll just go straight to Ms. Olubode. We've heard the great work MSD Mothers is doing, supporting innovation. So please, straight from the, I don't want to say horse's mouth, you're too beautiful to be a horse, but straight from the beautiful lady in red. So over to you.
Thank you very much. It's actually evening now because it's past 4. Good evening, everyone. Good evening, distinguished panelists that I have the privilege of sharing the stage with. My name, as has been said earlier, is Iyaduni Olubode. It means it is sweet to have a mother. And so it is extremely serendipitous to be working on the platform of MSD for Mothers. For those of you who don't know MSD for Mothers, we're also known as Merck in the US and Canada. And MSD for Mothers is an initiative focused on improving maternal health outcomes. As we are talking about private sector, we are a private sector company ourselves, and we're putting a stake in the ground and saying that private sector can improve the health outcomes, development, can contribute to sustainable development goals, and in this case, goal 3.1 around maternal health. So I hope I can navigate this easily. The real question that I believe that we're trying to tackle today is how can private sector be leveraged for public good, and in this case, healthcare, maternal and newborn healthcare. Yeah? I want to amend that question slightly. I want to say, how can private sector be better leveraged? Because I believe that we have very good examples of how private sector is being leveraged, but we want more. We feel that a lot more can be done to improve the health outcomes of pregnant women in Nigeria. And when we talk about private sector, you know, I think in the global health community, the case for public sector is made. We're no longer arguing for public sector. I think there's a consensus. Everybody sees that there's value in private sector. And in the conversations that we've had today around financing, that's the first thing that people think of when they think of private sector. Yes, we need more money here, not least because public funding is limited. And therefore, governments have to do a lot with very little. And so that definitely makes private sector very attractive. But then you have UHC, which is the hot button topic for governments all over, including Nigeria. Primary healthcare, those are the things we're talking about. How do we reach every Nigerian, regardless of where they are, and how do we ensure that they can afford quality care wherever they are? So private sector naturally factors into this mix. It factors into this mix because private sector is bringing innovation. We've heard from MDOC about the innovative work that they're doing, and so many other examples that have been shared today. Farm access, you know I'm a fan. I think that they're literally living and walking and breathing innovation in Nigeria in terms of how do you simplify quality and make that available, make it a currency for healthcare, so that even as we are broadening the health system, we're not compromising quality, which is critical. So many health innovators doing things in the health space. So there's innovation, and then there's expertise that is naturally akin to private sector when you talk about things like marketing, supply chain, logistics, reaching the last mile. That is where, you know, the private sector have really figured it out, and we can bring that in. And then I think most popularly as well is the reach, because many of the government hospitals cannot be everywhere. And then we have a lot of private facilities, you know, not across the spectrum from primary healthcare, but I think Dr. Chito also pointed out that the smaller ones are in the large in the majority, and then you have the secondary and tertiary care ones as well. So private sector is quite broad and is bringing a lot to this table. So wanted to share a few examples. You know, did you know that in many states in Nigeria, that a woman who is suffering from postpartum hemorrhage and needs blood can receive blood in not more than 45 minutes? Think of the traffic in Lagos and think of that fit, regardless of where you are. You're able to get blood, and you're able to do that because of an organization called LifeBank. They put a lot of resources, innovation, financing, thinking through the problem and trying to figure out how can we get blood to women who need it the most so that they do not die from PPH. That has taken a lot of innovation, a lot of creativity, a lot of doggedness in the environment that we're in. But this solution exists, and yet a woman is still going to die from PPH because she did not have blood. Yeah? MDOC, I won't spend too much time talking about what MDOC does because I think NECA has talked about it. But did you know that even as we have dwindling healthcare workers, that you are able to, that there are health coaches that can educate a woman, give her the necessary information that she has to manage her health so that she's entering pregnancy healthier and having a successful pregnancy, and she's not at risk of PPH because of anemia, or preeclampsia because of high blood pressure, or diabetes because she's been advised on how to eat, what kind of food to eat. Prevention is better than cure. I think the last example I'm going to make is the Pharmacy Council of Nigeria and the work that they're doing with drug shops, local drug shops, which are a form of private sector. Now, I did not know until I joined MSD for Mothers that you can actually prevent up to a third of maternal deaths. A third, think of a pie and divide it into 3. You can actually prevent up to a third of maternal deaths, the research shows this, by offering to women who do not desire to have children quality contraceptive services. That is significant. That is huge. So how do we take that third of the pie of women who are dying and prevent it from happening? The PCN have created a framework around drug shops, and many of these drug shops are in hard-to-reach areas, yeah? And they are mom-and-pop corner shops. You know what, we call them PPMVs in Nigeria, have taken them through a process of training and accreditation to ensure that quality does not slip, and are working together with a huge number of stakeholders. Pharmacy Council of Nigeria is the champion, but the work is being led by Society for Family Health with a slew of other partners that they're collaborating with. 3 minutes, she says. Anyway, those are just examples, and these are few examples. I am sure that there's so many more. These are the ones that we know, that we've worked with. How do we get more of these examples, the visibility? How do we give them the visibility they deserve? How do we encourage collaboration with the government? Like Ndide had said, it's regretful that we do not have as many as we would like, or any government representatives in the room, because I think that they're extremely germane to this conversation. I come here with the knowledge that I've gained from interactions with these stakeholders and on the platform of the work that I'm doing. And I'm also here to learn, and I'm also here with questions. And I'm really happy that Dr. Chito talked about the need for structure. And on that basis, I would like to introduce a resource. It is not our resource, it's WHO's resource, but I think that more people need to know about this. This is the Country Connector. And the Country Connector is actually an online space, resource center is what I would call it, developed by the WHO in response to requests from governments all over for how do we, to the question, how do we engage with the private sector? I think we need to recognize that there's a capacity gap in the government to be able to govern one health system, to be able to govern a health system that is not public or private, but one health system. And what WHO have done is created this resource center. Now, this resource center is not strictly for government, and this is where the private sector stakeholders need to key in. There's an opportunity for you to share the information about the work that you're doing, collecting information. You know, when Dr. Chito showed that picture of the giant, what came up in my head, the giant and the minion is what I tabbed it, is so many minions together can make another giant. And we need to have that sort of collaboration in the private sector so that you're building yourselves up into a giant that can talk face to face with the government. You're not going to be able to push as a single unit, but together. And there's so many platforms. Healthcare Federation of Nigeria, Pishan is also doing some work. The private facility owners are coming together. We need to see more aggregation. We need to see more evidence and more data, because you cannot argue with evidence. If you put evidence in front of your stakeholders and say, this is the statistics, this is how we've been able to improve the change, people will be very excited to see. So we need to stop talking without the data. We need to get together, get the data together. And this platform gives you the opportunity to share that data. On the other side, for government, it also provides information and tools and positive examples of how to govern one health system. Everything you talked about, from policy, engagement, regulation, what needs to happen, how can it happen. So just want to say, if you haven't heard about the country connector in private sector, it's www.ccpsh.org. Please put it in your phones, Google it on your way home, and share it. Nigeria Health Watch, our mandate to you, because the government is not here, we need to take this message. Everything that has been said here needs to be placed into the people who are making the decisions on behalf of
everyone else.
Everyone else, exactly. And with that,
thank you.
Thank you.
Sister
Thanks for indulging me.
Thank you. Thanks so much. Sorry, that's what happens when you're the last at the end of the day. But thank you. I think you made a lot of great points around really showing those three things. A lot of people may not have known about really. How do you, and something I think we'll talk about with you is how do you really, as a global organization, how do you build up local partners? Organizations that, if their capacity is built, you can also have many MSDs, mini MSDs around at community level, but we'll discuss that. Our last speaker is Dr. Tokes. I know you have a video, so I want to make sure it's available before you go on. Yes, make sure it's available before you start speaking.
Well, thank you very much for having me. Just to check that you can hear me to begin with, I'm a whisperer. So thank you. Can I begin by thanking our esteemed president of the Nigerian Students Association for assuring us that he will not be leaving the country. Quick message to our brethren in the diaspora: we do not want you to retire back to Nigeria. We want you to come back when you are at the peak of your prowess, to give to this country and to get the best out of this country as well. As the moderator has said, I have a 3-minute video. I will speak for 2, come back at the end, round up with 30 seconds. Dr. Vivian, thank you very much for inviting me. I think it's fair to say that the enduring sub-theme, or one of the enduring sub-themes of this conference, is that government has left the room. Absolutely. And that's particularly important because we're here talking about the collaboration between the private sector and the public sector. Let me begin by framing the context in which we are here gathered today. We live in an environment in which the median age in this country is 18. That means half of the people in this country are under the age of 18. Life expectancy is 55 or thereabouts. Some might argue for slightly less. Per capita spend on healthcare is about $70. To frame it in context, the average OECD country spends about $11,000 on healthcare. Okay? So health follows a social gradient. If you are poor in Nigeria, you are far more likely to suffer adverse health outcomes. What that means really is that in many ways, in many respects, health is a socioeconomic construct. Quite frankly, the two effective barometers of the state of a nation are the state of its healthcare and the state of its education. So I stand here before you.
Dr. Shite, before you continue, I just want to make sure that they don't think they're waiting for you to finish. They might want to play the video if it's ready.
Yes, I will give the cue to play the video.
All right.
No problem.
Whenever you're ready.
Thank you. So I'm here before you. I come from the coalface of private sector healthcare provision. At the Duchess, our strategic priority is to deliver access to affordable world-class healthcare. What that means, being the direct beneficiary of tons of money from the private sector, from the public sector, from the federal purse. We do not have to pay back high-interest foreign exchange loans in double digits. We've been the direct beneficiaries of interventional loans from the CBN and the Bank of Industry. What that means is that there's a huge responsibility upon our shoulders to deliver that access to world-class healthcare and to ensure that that collaboration with the public sector is firm, it is secure. What that means really is that I do not have the luxury of waiting for the government to come to the table. The onus is on us to break down the barriers, break down the doors, lay the table, and bring them to the table. Okay? So as an entrepreneur, very important to me is the fact that we need to have initiatives that are quick to market. So I cannot afford to pay lip service to that collaboration between the private health sector and the public sector. So I have a video very quickly to play for you. You can play it now, that's the cue. To show you what that means to us at the Duchess International Hospital. It's called the Duchess Waiting List Initiative.
My name is Vijay Soni and I'm a student, just finished secondary school, processing admission. Learning fashion designing, so one particular day I was at work and everything, doing my job and all, then I started palpitating, noticed I was sweating a lot, then went to see a doctor. Then when they called my mom, like, oh sorry, your daughter has an hole in her heart and everything.
It started a little over 2 years ago. I had a terrible business failure. I developed, I was not sleeping at night. I would just wake up, night sweating, restlessness. The most high point was breathlessness. You can't breathe, you can't sleep, you can't lie down. That happened over a year ago. I was rushed to the hospital.
The WHO recommends one surgeon to every 40,000 of population. In Nigeria, we currently have 10 active cardiac surgeons for a population of 200 million. So that's probably what? 1 to every 20 million people. So that's a huge gap. So in terms of personnel, we are a far cry from what is recommended. In terms of capacity of numbers of people who need surgery, it's even worse. So we need to increase capacity. 2 months ago, I had 14 people on the waiting list, and I'm doing just 2 a month. So if I'm doing 2 a month, it will take 7 months to get to patient number 14. So that's why the collaboration was a necessity.
The Duchess Last Week Waiting List Initiative is a collaboration between the Duchess International Hospital and the Lagos State University Teaching Hospital. Its purpose is to bring affordable heart surgery to the masses, to the population, many of whom would not normally be able to afford this level of care. What we have tried to do through this initiative is to cut down that waiting time for patients by moving their procedures across to the private sector. So in effect, they have the benefit of a fantastic service like you can have at the Duchess International Hospital at no additional cost. And they're able to benefit directly from the level of service and care that a patient can expect in a high-end private sector hospital.
Right now I'm feeling better, the pain is not there, the injury is actually healing and everything. Throughout the procedure and everything, I felt chilled, I felt safe. I didn't feel the tension of, okay, I'm going to have an open heart surgery. So I was very chilled and Dr. Falashe did it and here I am.
I walk now unaided. No panting, no breathlessness. I'm as fit as a fiddle.
The collaboration we have with the Lagos State University Teaching Hospital is intended actually to extend across a wide range of specialties and services. We happen to be starting with cardiac surgery. We're very pleased that that is extremely successful right at the start. But yes, there is every intention to spread this across to a wide range of services.
Well, thank you. Thank you. In the 60 seconds I have left, I will say this. The private sector has a responsibility. Okay? Government is too big, too unwieldy, too inefficient, too broke to expect that they will lay it out for us. Okay? The private sector must break down the doors and construct the solutions that we need to deliver the quality that we need to the population. So we're talking about the Duchess Lassuth Waiting List Initiative for Open Heart Surgery. I'm speaking about capacity. I have the capacity, which means expertise, infrastructure. Okay? And within a few short weeks, we were able to cut down the waiting list in the public sector for heart surgery by 6 months, straight away within a few short weeks. Okay, so healthcare is serious business. It's not a talk shop we should get together here to engage in. We all have resources that we can bring together. Okay, and that kind of significant product in the interest of patients is what public-private sector partnership should look like. Thank you very much.
Thank you, Dr. David. That was a great way to end our presentations. We're going to just go right into it. We don't have a lot of time. And I'm going to lay the framework around the 4 issues why, the 4 causes of, the 4 delays that make women die in maternal health, because this is still a panel on maternal health. So first of all, is delay in recognizing danger signs, delay in deciding to seek necessary care, delay in reaching the health facility, and delay in receiving care at the health facility. So I'm going to allow you to wonder which bucket you fall into, right? So I guess I'm going to throw it at Dr. Movisi. Delay in recognizing danger signs, right? Now, I know and I think MDoc is doing excellent work, but I'm a doctor. I guess I already know a lot of stuff. What do you say to people who feel like, as you said, digital in health, it's coming, it's big, but of course there are the other issues that we can't control in terms of digital penetration being very minimal in Africa, women being, the inequity in accessing digital health is still in women. So what do you say to people who say that, is it really something we should be investing in right now? And can we really depend on it in terms of using it as a means of maybe women assessing the science, or is it strong enough a platform to use generally when we are talking about maternal health care in that aspect?
Thank you for, can you hear me?
No, maybe use your side, yeah. No. What of the one that said okay? Yeah.
Can you hear me?
Yes.
Okay. So we definitely work on delay 1 and delay 1. Quite frankly, we work on all delays, but our main delay is 1. And the reality is, I actually think we also have to be careful because I've actually found the greatest bias. Can you hear me? Thank you. Oh, okay. Thank you. Okay, I found that the greatest disbelievers in digital sometimes are actually in the healthcare side. And if we think about it, in healthcare, for some reason, the healthcare sector is always the last one to adopt anything, particularly in technology. And so I think it's also very important for us to check our own biases. Our mobile phone penetration rates are actually very high. There is unquestionably a digital divide. But at MDOC, we've been able to support women to literally learn how to use a phone, whether it's a basic phone, whether it's a smartphone, because a lot of women have access to a smartphone. Many of them don't own the phone. It's their husband's phone, it's their sister's phone, their brother's phone, but so therefore they only know how to use it for SMS. But when you invest in building their digital literacy, before that, when you invest in their trust, I want to highlight it again, invest in their trust. Because again, historically, they have been failed by the Nigerian healthcare system. They've not had access to people who actually listen to them all the time, who take the time to actually explain things to them. They have a thirst for knowledge, and you're actually able to leverage the phone to teach them how to count fetal kicks. You're able to teach them that it's eating that Indomie or Indomie noodles or whatever, they can cut it in half and take some type of small vegetable. We can teach them how to grow seeds, even though they are living in one room with 10 people, by taking some dirty water from outside and actually growing seeds that actually lead to ugu growing that they can eat for their health. And it translates into outcomes. We've been able to show a 3x increase in terms of women exercising. These are pregnant women, these are women of reproductive age, because of having access via the phone. We've also been able to show that a 40% increase in their confidence. The evidence shows that when you invest in a woman's confidence in terms of her health, it actually leads to improved outcomes. So MDOC invests in that. We actually assess them for their self-efficacy at the beginning of the enrollment onto our platform. So increase in 40%. We've been able to increase their digital and their literacy as well. And what has that translated to? Sustained reduction in blood pressure in women with hypertension by up to 70%. Sustained glycemic control. What does all that lead to? A reduction in the likelihood of preeclampsia and eclampsia, and then ultimately being able to be there for their babies, and healthier babies. As a pediatrician, I want to say that healthier babies and healthier living. So we at MDOC, we don't play with data. And our data shows it. Hopefully we'll have a peer review publication out by the end of the year that we can share with you that underscores this. But the data is there. Yeah. And so it's time for us to take away our own biases that are preventing women being able to adopt more and more of these. This is working. It's time for us all to take it by the horn.
Thank you very much. Thank you. I think that really summarizes it. Digital is a platform. It is viable. We need to invest in it. We need to be comfortable with it enough to use it. And our MC is looking at me. I'm not looking at you. We are continuing. Now, the second delay, sorry, I know, we'll soon be done. Delay in deciding to seek necessary care. So that, Dr. Chito, that's for you. That has a lot to do with the healthcare system, the woman's trusting the healthcare system, and it feeds into what you said around trust between public and private care, the public system and private care system. The issue now is that if we don't have that trust, then the end user, who is the woman, loses out. So it's easy to say trust, but how do you build, well, first of all, trust that has been fractured over the years? And how does one, now this trust, is it from the public system or to the private system? Which one is, because it's very important. Who is the trust needs to come from which is the weightier part? Are you saying trust from the public system to the private, or private to the public? And how do you strengthen those linkages to ensure that at the end of the day, the beneficiary, the woman in the village far away, can benefit from that kind of long-term relationship?
When I spoke about trust between the public and the private health sector, it was really a case of the fact that the government doesn't trust the private health sector in terms of the misperception that they'll put profit above patient care, and then the private doesn't trust the government in the respect that at the end of the day it will not be a sustainable relationship and it may lead to further burdening of their private health sector. So in many ways, I think really one of the things that we don't do enough is dialogue and sit down and hash these perceptions out. And yes, patients really do lose out. Like one of the questions we've asked before is that sometimes the way now you have a lot of private tertiary hospitals that have a lot of innovation, yet despite that, you rarely see where someone in the government is referred to somewhere in the private, even if they know that the only place to assess that care is in the private. So we haven't, when we talk about relationship, we haven't yet developed such a strong referral system that includes the private sector. Many times you can go to the public, for example, and their CT scan is not working. And you know fully well that you need a CT scan. And instead, sometimes instead of them to refer that person to the private, the person has now this delayed access to imaging that is needed to solve that problem. In terms of maternal health, you know, I always look, I mean, being an OB, of course, it's very simple for me in the sense that when you think of maternal health trust, a lot of times, and remember that even in the public system, you know, they pay for delivery. I mean, people have this impression that in the public sector, maternal health is free. It's not. All right, it's not free, and it may sound as low amount to us, but a huge amount to them. I know that in FCT, in General Hospital, you hear women say they have to put down 20,000 or 23,000 naira, and that sometimes is a lot. And that's where coming in and trying to build a partnership that allows us to be in the primary health space as well. So as I have an MOU now with a primary health center, and a lot of times I go there and I'm able to bridge the gap of, look, I'm going to send you here, we're going to pay for this, or I'm going to deliver certain care right there in the primary health center. And in that kind of partnership, that woman is getting that care they need because they will never go to the general hospital to pay that money. So this is where I think when you have that partnership, and you're able to really, like for me, it's like, maybe I have a global perspective. Remember, I come from abroad and I may not have, sometimes you have some private sector that will tell you, we don't trust. But I'm optimistic. I believe there's nothing that cannot be solved, and there's nothing that we need to try it first. We haven't even tried it first. There are not that enough templates to do that. So I think that's where I'm talking about trust, and why trust and not being able to trust each other will affect care and delay care as well.
Thank you, Dr. Chito. We're rounding up. I know we need to go, but I think just to our last two speakers to contribute to the discussion. The third delay, and I think building on what you said, now becomes you have the trust, receiving care at the health facility. Dr. Chitobi, I think what you shared was was awesome, quite remarkable really. And one of the main issues we have in Nigeria in terms of maternal health is skills transfer. You have a world-class institution like Duchess in the middle of Lagos. My sons call it the cake hospital. I want that cake hospital, you know. But how do we, and as you are doing, you know, impacting a public facility, but that is an innovation that really hasn't happened, it's not common. And it's something we need, as you said, that can improve maternal health outcomes. So I want to ask, first of all, in terms of skill transfer, what do you think would, like just pick one thing, would incentivize a private sector provider to do that kind of work within their space? Because the opportunities are many. And I think private sector providers are willing. So what would really motivate and inspire, if you're going to pick something, like what would be the, I don't know what's motivating Duchess, you know, but what do you think for more private providers would motivate them to be able to do that, want to do that?
Money.
Okay, thank you very much, sir. I think the case is closed. You have been very clear.
May I contextualize that
Yes,
just a bit? What I mean, really, is support. So we see ourselves as, of course, a private sector organization, but the Duchess Hospital is as government as it gets in the private sector. The reason being that we have been the direct beneficiaries of government money, low interest rate loans to set up. The cost of setting up healthcare in this country, given the double-digit interest rates that we have, is prohibitive. And government needs to give some consideration to that. I think if the private sector were to have that kind of firepower behind it, like we have had, the incentive would most definitely be there to do the sorts of things that we want to happen in the public sector. So think about the Duchess really as a public sector organization with all of the efficiencies of the private sector, simply because of the way we are set up and the partnership and funding that we've had from the federal government.
All right, thank you. Awesome. Thank you. That makes it very clear. And I think the way you put it, if our other partners were in the room, the public sector, I hope they're listening and will encourage such collaborations. And last but not least, the last delay is in reaching the health facility. And I think you mentioned a lot around that, around PPMVs, these other things around that. It must always be the health facility. We do have local structures that can support women that are pregnant and even just providing information, as you said, contraception. So I'm very interested in understanding how, and just your ideas now, when you work in global organizations, it's always the global thing. But there is a point where we need to start strengthening organizations in Nigeria, either for advocacy, to be able to create demand with the women, to know their rights, create demand, so that at the grassroots level you have facilities and structures they can actually engage in. It can be a woman that says, oh wow, I can open a shop where I sell only contraception, and she has access to the market women, she has access to the beneficiaries we're looking for, And at some point, bigger organizations should start thinking of building these smaller based organizations within communities. So as someone who works in MSD, global organization, I would just like to get your thoughts on that for the future in terms of sustainability, and because we all work in this space, but providing funds is good and support and all that. But at some point, we do need to have local structures that begin to advocate for themselves, that begin to support, know that they need to provide these commodities. So it would be nice to hear your thoughts on that.
Thank you.
To close.
Thank you so much for raising that question. I think you are very right. We need to start looking at ourselves. And this is an ethos of how we work at MSD for Mothers. We work with local organizations, with people who are on the ground. We work with organizations like Life Bank, founded by Temi Giwa, with Society for Family Health in Nigeria, with MDOC, with SKIDA, who are based in Nigeria, with Nigeria Health Watch. We are working with organizations. One of the things that we're doing is that we have a global initiative called Strengthening Systems for Safer Childbirth. And it is with the understanding that too many people are deciding what solutions to deploy in localities without the voice of the people on the ground. And the idea is, how do you come together as a group? The collaboration that Nneka spoke about, to solve a problem in your locality. Bring to us your ideas around how you want to solve that, and let us support you, along with other funders, to make that a reality. And we're currently having 2 coalitions in Nigeria. One is led by HSDF, Project Aisha, which you would have had in your folders. Another is led by Helium Health, which is also is called For Moms. But the idea is, many times, the farther away from the problem, and I heard this somewhere, the farther away from the problem, people seem less optimistic about solving the problem. People who are immersed right in the problem, they can tell you what the solutions are. They can tell you how to make their lives better. Yeah, exactly. And so it's very important in the work that we do that the women who we are seeking to save, the women who we are seeking to support, the pregnant women, their voice is rooted from identifying the problem to crafting the solution, to testing the solution, to evaluating the impact. You cannot remove the women and the communities that they live in from whatever work that you're doing. It's a vital way in how we work as an organization. It's a vital way that we require our collaborators to work in.
As well. Thank you. Thank you so much, panelists. Thank you. I think we've come, as our MC has shown, we've come to the end of this session. I hope it was interesting. I hope you also learned that indeed, at every point of care where there's a delay that leads to a woman dying, there is a solution. So that's the point. Between our 4 panelists, They gave solutions, or at least offered solutions to the 4 delays we have that leads to a woman not seeing her child or a child in the process dying with the mother. It doesn't have to be so, and Nigeria is a leader in so many things. I'm sure we can be a leader in this as well. So thank you.
That's a very persistent hand. So.
All right. Let's give them another round of applause, please. Thank you very much. I see a hand up there. I noticed that. We're way beyond time, but I want to thank you so much for waiting. Thank you so much for participating in the conversation. This has indeed been a worthwhile conference. A conference means we have various aspects of a conversation and we go in depth into it to prefer solutions. So we'll quickly take your question. I need you to ask that question in 20 seconds, if possible. Please come on forward. Okay, we have a microphone.
Thank you so much for this wonderful session, most especially this one. My question is that I'm Abi by name. I represent Saiti Business Medical here. My question is for the board of directors for hospital CEOs. Some time ago, I attended a conference of which it is for African medical tourism centers in partner with some medical hospitals in Ghana. And I noticed one of the great things that Ghana's healthcare professionals are doing, and what they are doing is the fact that they actually form a kind of coalitions for private health sectors in their countries by trying to bring in a lot of health sectors together by trying to turn their country into medical tourism destinations. So I want to ask, since morning we've been talking about brain gap to achieve healthcare resilience in our countries, but then we've not talked about how we can turn our country into a medical tourism destination. Yes, we actually have the best hand here, and we have sometimes, we have somehow best facilities, but then there is no this kind of coalition, because the reason why I'm bringing this question is that I've actually experienced a case whereby I led a medical fundraising, and we raised about 36 million naira, yes, for one of our students at the University of Ilorin. And the student actually had acute myeloid leukemias. And after the end of the day, we were unable to transport the patient to India to go and have the MT surgeries. Eventually, the guy later died. And I believe so that if we actually had a kind of a facility that can actually do this kind of surgery operations there, we will not have to, you understand, go into that kind of stress by transporting the patient. So I want to know what are the efforts that the board of medical directors here are actually doing, to ensure that we actually turn this country into a medical tourism center. Thank you.
Thank you. And I think most of our conversations have been directed in that direction. I remember one of the speakers mentioned earlier how much money we're spending on medical tourism, and how if we convert the medical brain drain into a gain, it's not just enough for the over 200 million Nigerians, then we can also attract other people. For now, we've got a deficit. We've got a great deficit. But if we take the ideas that we've shared all through the conference today, then we can begin to head in that direction. All right, thank you all for being an amazing audience. The Future of Health Conference 2023 is about to wrap up. But before we do this, we want to tell you what the theme is for next year, because it's going to come back bigger than this in 2024. Please help me welcome to take us through what we look forward to in 2024, the Director of Programs, Nigeria Health Watch, Dr. Kemisola Agbaoye. Your hands together, please.
Okay, thank you so much, Memimo. Thank you everyone for sticking with us up until now. I know you all plan to be out of here before 4 p.m., so we do not take this for granted. Thank you for being so patient. The discussions have been enlightening, and we look forward to a whole lot more next year. We're going to watch a very quick 2-minute video that will tell you what to look forward to next year, and then we'll round up. Thank you.
Climate change is a severe reality that affects our environment, food security, and the health of our population. It is no longer an impending threat as unprecedented extreme events are being brought on by changing weather patterns.
The disaster disease surge is causing to our community. Our people have been running helter-skelter. You can see some of them packing their loads. I don't know which destination they are heading to.
A mixture of water, gas and oil blasts the swamp and surrounding tropical trees, shattering the silence in Nigeria's Nembe.
Hi everyone.
It's located in the country's oil-rich delta.
Hi everyone. Apologies. That was the wrong version. Okay, so while we wait for them to queue up the right one, I just wanted to once again thank everyone. I want to use this opportunity to thank all of the speakers from the first panel up until the third panel. Thanks to all of our sponsors and partners for just believing in this cause, for being a part of these discussions, for driving discourse. You know, I was discussing with one of our sponsors earlier, and we talked about how important it is for discussions like this to be had. If we don't bring these discussions to the fore of public knowledge, if we don't continue to elevate these issues for policymakers, for the public to be aware of and to engage with, then the road to improved health outcomes, the road to better healthcare systems would be fraught with a whole lot more challenges. And the fact that you're here, you're engaging on social media, you're joining the discussions, and you're asking questions is testament to the fact that Nigerians actually do care about these issues. And as long as we continue to talk about them, as long as we continue to drive discourse, then policymakers will take notice and they will start to make the changes that need to be made. We've talked about public sector and public-private integration and how important it is. We've heard about an enabling environment. We've heard about governance. We've heard about money and financing. And we've heard about how Nigerian medical students want to stay back. What are the pull factors, or what are the things that need to be in place to help them stay, to reduce the brain drain? What are the things that need to be in place to reverse the brain drain and get a brain gain instead? We've heard a lot today, and we are really grateful at Nigeria Health Watch that you choose to join us and stay till this time. So please do not rush off. We're going to take a group picture. There is lunch served already. And please, there's a QR code already on your tables. Please scan it and give us feedback. One clear feedback I'm expecting is, oh, you guys took too long. So that's noted, but tell us more about what you enjoyed, and we would love to improve. All right, so unveiling next year's conference theme. I'm hoping this is the right video this time. It's just 2 minutes long, so please stay. I'm sure you're curious what we want to do next year.
All right, everyone. While they're setting that,
Climate change
there we go.
is a severe reality that affects the environment, leading to unprecedented extreme events like floods and droughts, brought on by the changing weather patterns.
The disaster disease surge is causing to our community.
Climate change is a severe reality that affects the environment, leading to unprecedented extreme events like floods and droughts, brought on by the changing weather patterns.
The disaster disease surge is causing to our community. Our people have been running helter-skelter. You can see some of them packing their loads.
A mixture of water, gas and oil blasts the swamp and surrounding tropical trees. And the spill, now in its third week, is a reminder of how the once fertile area is now one of the most polluted on the planet.
And the rain we have here is acid rain. The water, you cannot use it for anything because the water is completely black. So there have been an emergence, especially there's an emergence of unknown diseases in our area here of recent.
They affect me well. The smoke, they affect me well. Sometimes it go make me the cough. Sometimes it go make me the breathe. Another breathe well.
A growing body of evidence points to the direct and indirect health impacts of climate change, such as food insecurity and malnutrition, infectious disease emergence and re-emergence, heat-related illnesses and mental health issues like anxiety and depression. However, the linkages between climate change and health are still poorly understood. Global awareness of the health impacts of climate change is increasing, thanks to the discourse at the global level by the World Health Organization and the Organization for Economic Cooperation and Development. However, these discussions must be brought to regional, national, and local levels where the impacts are most felt. For years, Nigeria Health Watch has explored the future of healthcare in Nigeria, from universal health coverage to innovations in health. Now, it is time to focus on the climate health nexus and build evidence for a climate-resilient local health system. Unveiling the theme of the 2024 Future of Health Conference, the Climate Health Nexus, making the evidence visible.
That deserves a massive round of applause. So 2024 is just around the corner. I hope you know. I hope you know that 2024 is just around the corner. And next year promises to be as exciting and even more than today has been. One final thing you have to do for me before you go have lunch. Can I see your phones one more time, please? Just indulge me. It won't take a long time. Can I see your phones? All right. There must be one thing that struck you throughout the various conversations today. Can you write that on Twitter for me? And use the hashtag PS4 HealthNG. Hashtag PS4 HealthNG. Just write out one thing that stood out for you today. In fact, you can do a thread, but for now, write one thing. Later, go add up to it. But for now, please write one thing and use the hashtag PS4 HealthNG.
On behalf of the Nigeria Health Watch team, we want to sincerely thank you all for staying with us till the end of this important event. Thank you so much. We really appreciate. So sorry for going beyond time. It's not in our culture, but thank you for also indulging us, engaging and staying alert to, till the final session. Thank you so much. Thank you and thank you.
Okay, we never gave everybody a round of applause. Did we do that? Let's do that. Hold on. I'll call the number, you clap. Are we ready? It's for yourself, so make it the best today. Are you ready? Let's go. 1. Together now. Let's do together. 1, 2, 3, 4, 5, 6, 7, 8, 9. Hold on, make the last one really thunderous now. 10. You are awesome. Thank you for being here.
Thank you. On that note, we want to say this is the end of the 2023 Future of Health Conference. Thank you so much to the Nigeria Health Watch team who worked behind the scenes to make this event possible, and all our partners, because without them we wouldn't have been able to achieve this, and all the vendors, all the people who worked really hard to make this possible. Thank you all so much. We have lunch served, 2 spots. Please get something to eat before you head home. We really appreciate your staying till this time. Thank you so much. Photographs.
All right, we're taking group photographs. You can come up here. Let's take photos with the partners and sponsors. Yeah. Okay, partners and sponsors, can you please come up stage to take pictures? Please come on stage to take pictures. If your organization partnered or sponsored, please come up stage to sponsor. We have 3 serving points for lunch. Please go over and have your meal. Don't worry, it's not cold. It's been kept really warm. Partners and sponsors, please come up stage for a group photograph. Yeah. Come on stage. We're waiting for you. Partners, sponsors, please climb up stage.